right, it looks like we've got almost everyone here. We're gonna give people another about 2 minutes to log in and then we'll get going if that's okay with you, Dr. Shea.
No problem.
Perfect. Oh, I see Tui. Tui, how's New York treating y'all so far?
Boston, but it's good.
Boston.
Oh, Boston, that's right.
Yeah, it's good. Can't complain. Hi, residents. We miss you guys. I hope the department's not too much of a disaster.
Yeah, we're surviving.
This too shall pass. The third years will be back Thursday. One more day.
Okay, I think we probably have just about everyone here. So we'll go ahead and get started for the morning. Residents, remember, I'm going to drop in after every talk. I'm going to drop in the SurveyMonkey links, and that's your attendance. So make sure you hit those up. And then we've got, so to start us off this morning, we've got Dr. Shea, who's with our ID program here at UCI. Very, very excited for this talk whenever I saw it on the schedule, because I feel like COVID has been changing almost day to day for the last year and a half. So I'm really excited for a summary and to see where we're at now. So Dr. Shea, if you're ready.
Yep, thank you for inviting me. I'm Lanny Shea, one of the ID faculty here at UCI. I'm also the clinical lead for the COVID task force at UCI. So things have been changing a lot. So it is hard to condense everything into 30, 45 minutes, but I'm trying to give you mostly, I did not go into all the details, all the studies about things. I just gave you guys the bottom lines here and try to incorporate a lot of visual pictures and things like that to make it more interesting. So let's go. So this is just I thought this was a fun timeline showing the major events from December 2019 when the pandemic started to about a year later, so December 2020. So as you guys know, this is now almost December 2021, which is not included here, but I just wanted to illustrate all of the things that happened in the first year of the pandemic, which is like super fast. And as you can see, the first case was in December, and then very soon after, there's testing, there's vaccine trials, there's remdesivir gets approved, and all of these things. So things are going faster than it's ever been, and it's both good and bad, because as you guys know, at the beginning of the pandemic, some of the data that came out was not helpful, yet there was just tons of it, right? So it's really good where we are at now, that there's much more evidence-based medicine to tell us what to do. So this is the way the pandemic is going. As you can see at the left upper corner, 2 days ago. This is when I got the slide from the Johns Hopkins website. This is from Monday. And as you can see, the total cases is over 240 million, almost 5 million deaths worldwide. And then this is the map that you can see. And here in the US, this is how we're doing in terms of the level of activity. I think this is talking about the number of cases and the community cases in the broken down by state. And as you can see, California is doing better than almost every state except similar to Puerto Rico. And this is the one for the 7 days case rate in the past week per 100,000 people. And as you can see, California is the lightest color. So we're doing better than other states. And then also over here is the daily trends in the US. If you go back to January 2020 to currently, as you can see, we had the huge surge in the middle of the winter last winter, and then a little bit over here during the summer when the Delta variant was kind of sweeping across the country. And as you can see, now the cases are down, and you guys can feel it down in the ED that the cases in the country is down. And we basically, it's a breather time for us, and it is expected to surge again a little bit during this winter. So here is the daily trends in California, which matches what it was the rest of the country. The huge surge in last winter, and then the bump in the summer, and now a kind of a lull for the fall. This is Orange County data. And so as you can see here in the middle right here, you have the blue dots is hospitalizations and the purple line is ICU admissions. It follows a similar trend. And currently we have lots of ICU beds. Ventilators are available. And as you can see, there's currently in Orange County, 200 patients or so, 44 patients in the ICU. Also Orange County data, this is just basically broken down by age group. As you can see that these are just the cases, so people testing positive, and the most number of folks cumulatively is in the young people, 25 to 34-year-old group. And then in terms of ethnicity, here in Orange County, the Hispanic or Latino population got hit very hard. And then in terms of deaths, the most number of people who died actually were the elderly. So even though the younger people are getting sick, it's the elderly who end up dying. And as you can see here, it's kind of almost a linear plot of the people who died by age group. And then Hispanic folks also, a lot of deaths. And over here, to draw your attention, there's a little bit of a male to female predominance in terms of the deaths across all age groups. There's quite a bit of speculation on why males tend to have more severe disease, some things to do with protective mechanisms of estrogen in terms of the inflammatory phase of the disease, etc. But nothing has been really proven so far. So just one slide on the kind of summary of what I was talking about earlier. As of about October 18th, over 240 million cases, more than 4.9 million deaths worldwide. In a survey of about 1.3 million lab confirmed cases in the US from January to May in 2020. This is earlier in the pandemic. So as you can imagine, we have gotten better in terms of managing these patients. So at least back then, 14% were being hospitalized, 2% in the ICU, 5% died. And the percentage of patients who died was 12 times higher among those with medical conditions than those without medical conditions. And the percentage of those who were hospitalized was 6 times higher among those with medical conditions compared to those without medical conditions. And the mortality rate was highest in those aged greater than 70 years, regardless of the presence of a chronic medical condition. And the worldwide case fatality rate currently is about 3.4% and varies by country. One study that I saw was that it seemed like they had, out of the countries that had more than, 500,000 cases or something, France had the worst case fatality and Germany had the best. And the male to female case fatality rate was elevated through all age groups, as I mentioned earlier. And the CDC defined some of the risk factors for severe COVID-19. And as you can see, these are your usual ones that you think of, folks that might do poorly. Cancer, chronic kidney disease, lung disease, dementia, diabetes, Down syndrome, heart disease, HIV, immunocompromised state, liver disease, obesity. But obesity, actually, you don't have to be that obese. Apparently, just being overweight is a risk factor with a BMI of 25. Pregnancy is a big one. Sickle cell, smoking, organ transplant or stem cell transplant, and also substance use disorder. Pretty much when you're looking at this list, you're thinking that's like almost all the patients. So usually speaking, a lot of our patients do have risk factors. So just taking that into consideration. So clinical presentation very quickly, since we have all seen too many COVID cases. So incubation period is still up to 14 days from exposure. The median onset of symptoms is between 4 and 5 days. And it's actually turned out over time that I have seen this is pretty accurate. And in most adults, if dyspnea were to develop, it tends to develop between days 4 and 8 after symptom onset. although we have seen a few cases that came on after 10 days, and presumably that is mostly due to the inflammatory phase of the disease. In a report of more than 370,000 confirmed cases in the US, 70% of the patients will have fever, cough, or shortness of breath as symptoms, 36% muscle aches, 34% headaches. And then other less common symptoms include nausea, vomiting, diarrhea, dizziness, rhinorrhea, loss of taste and smell, sore throat, abdominal pain, and anorexia. On chest x-ray, most common is bilateral multifocal opacities, as you guys have seen. On chest CT, we have seen different presentations, but most commonly bilateral peripheral ground glass opacities. It's almost like if you guys have seen CT scans of patients with PCP, where it's a central ground glass opacities, these are the kind of mirror image or the opposite of it. Not the mirror image, but the, what do you call it? The black, when the black and the whites are interchanged. So it's a peripheral ground glass opacities, and areas of consolidation can develop later in the course of the disease. Lab abnormalities, we see lots of leukopenia, lymphopenia. Those are actually bad prognostic signs. Elevated CRP, D-dimer, ferritin, LDH, and ALT. This is a primarily pulmonary disease, as everybody knows, but can have a multi-system involvement and complications. And a big one is thromboembolic events, and this is highest risk in critically ill patients. So this clinical spectrum of SARS-CoV-2, which is the virus that causes COVID-19, can be very variable. It ranges from asymptomatic to critical illness. And among a case series of 72,000 people in China, 81% have had mild disease, 14% had severe, and 5% were critical. Patients with certain underlying medical conditions are at highest risk for progression to severe disease, but because it is not always the case, it is kind of, the people doing research are still trying to find out, try to find markers and different tests to try to identify those that will progress to severe disease. As you guys have seen down in the ED these days, the unvaccinated are generally the younger crowd, many who don't have underlying medical condition, yet they progress to severe disease or critical illness and are in the ICU. And I am currently on the ID consult service, and I've just recently seen a couple that were otherwise healthy but unvaccinated and is on ECMO or on the ventilator for a month. So it's difficult to predict. And the infectious complications in patients with COVID, just a word about a bacterial co-infection at presentation is actually rare. Many times we think that, patients coming in, they're short of breath. On chest x-ray, you can't, they've got this kind of, ARDS picture already. You can't rule out community-acquired pneumonia on top of the COVID-19, but it turned out that in studies that folks did, that is actually quite rare, 0 to 6%. So in general, we're saying if the patient is at the earlier course of disease, meaning they just got sick in the 4 to 5 days range, they're short of breath, and you have this bilateral patchy opacities, you don't have to give them antibacterials. Because the rate of co-infection with a bacteria is actually low. There's been some reports of co-infection with, let's say, RSV or influenza, but that's a whole other situation. And generally, obviously, we test for those as well. Other infectious complications in these patients include reactivation of latent infections after the corticosteroids or tocilizumab that we give them. There is data showing that people can reactivate their TB and things like that after they get the tocilizumab, but that's also later on in the course of their disease. Nosocomial infections with prolonged hospitalization, I see that on the ID service all day long. It is really tough to determine what is going on, but most of the patients do develop ventilator-associated pneumonia when they stay in the hospital long enough. And then, of course, opportunistic fungal infections. There was a lot of press in the summer out of India where there was a bunch of mucormycosis on top of the COVID. In this country, we haven't really seen a lot of mucormycosis with the with COVID. We have seen some pulmonary aspergillosis following COVID, and generally those occurred later on in the course of disease. So a little bit about the pathogenesis, just to be complete. So SARS-CoV-2 is a brand new strain of the beta coronavirus. It's enveloped as positive sense RNA virus. The structural proteins include the spike protein, envelope membrane and nucleocapsid proteins. So the spike proteins basically gets all the press because that is the target for the vaccines and many of the interventions that we do. The genetic sequence of SARS-CoV-2 was found to be 80% identical to SARS and 50% identical to MERS. So MERS is the Middle East coronavirus. And whether the SARS-CoV was originated from bats or transmitted through a pangolin as an intermediate host to humans is still questionable. So just in case anybody's wondering what a pangolin is, I showed a picture, and it's actually very funny because I was thinking, like, I don't think this animal has gotten so much press since COVID has come out, because I actually had no idea about this animal at all. So interesting. Also, the ACE2 is a membrane-bound protein that plays an important role in the renin-angiotensin-aldosterone system, and it's expressed in different organs. And this ACE2 has been identified as a receptor molecule for the cellular entry of SARS-CoV-2. ACE2 positive cells are the targets and are susceptible to SARS-CoV-2 infection, and hence the clinical presentation is so varied because we have ACE2 receptors in your lungs, which is the most, everybody knows about that. But, we have it in the kidneys, in the brain, in the heart, even in the pancreas. So it's all over the body, and hence a lot of the clinical manifestations are tied to this fact. And COVID-19 progression can be divided into 3 phases. The first is the early infection phase involving a lot of viral replication and mild symptoms. This is the phase when you go and do the testing, is the most likely to be positive because it's the viral phase. And this is the phase where your antivirals medications are going to be helpful, like remdesivir, because there's active viral replication. Some of the data, just as a caveat, because if you look at some of the NIH data or guidelines about when to use certain medications for COVID, they often recommend, let's say, remdesivir for the early viral phase, right? Obviously, because it wouldn't be helpful in later phase of the disease. However, just in your mind, know that a lot of the data on remdesivir and such the trials were done with the original virus, the wild type virus. And so during the subsequent surges, let's say with the Delta variant, it is believed that the viral replication potentially can go on for longer than the very early phase because of the viral load being so high. So that's why you will see that there is difference of opinions in terms of if a patient is intubated with this disease, whether or not you give something like remdesivir. Some of the guidelines will say, no, it didn't show any difference for patients on a ventilator, so you shouldn't give the remdesivir, but others feel that, well, it's an antiviral, so it is possibly able to help and there's little downsides to giving it. So you may have to kind of decide that for yourself. The middle phase of this disease is a pulmonary phase, which involves adaptive immunity stimulation and predominance of respiratory symptoms. And then there is the hyperinflammation phase, where the patient may develop ARDS and other hyperinflammatory manifestations. So this is the testing guidelines from the NIH. I just wanted to call your attention to the fact that they recommend, obviously, PCR testing which is the kind of standard nowadays, and it's pretty widely available. But I wanted to mention down here, they mentioned against the use of serologic testing to either diagnose acute infection or to determine a person's immune status. There are different reasons for this, but the bottom line is that antibody testing, though, as it is available commercially, doesn't really measure your neutralizing antibody. So it is not really helpful in determining whether the person is immune or not. And also in terms of immunity, there's also cellular immunity in addition to humoral. So it doesn't necessarily tell you if you have, there's no way to test for cellular immunity. So a word about antigen testing, these are the ones that you can get like from CVS for 20 bucks or something. It's less sensitive, but highly specific. So if a person comes and says, oh, I did this test at home, it is positive, it's actually very specific. So if it's positive, then it's positive. It's low cost and fast turnaround time, as you know. So folks now, instead of trying to make an appointment at a drive-through or something, they're turning to just going to the pharmacy and picking these up and doing them at home. The sensitivity is really not great. So if a person is symptomatic early in the disease, it's more likely to be picked up, but then even then, at best, it's about 70% sensitive. So generally speaking, we're saying if you, I think the health department and the CDC are saying that your algorithm for testing is if an antigen test is negative, you should follow it up by the PCR test if you have clinical suspicion for this disease. So a word about the variants. Like other RNA viruses, SARS-CoV-2 is constantly evolving through random mutations. So this whole thing about having variants is not a new thing. It's designated as variants of concern if they display certain characteristics, such as increased transmission or virulence. Variants of interest are those that are important but have not yet been fully characterized. And in September of 2021, the CDC added a new designation called variants being monitored. These are variants that have potential serious impact but are circulating at low levels in the US. And one such thing that folks are that the CDC is monitoring is something like the Delta Plus that you guys might have heard about that's circulating in the UK. That variant has already come to the US and I think has already been detected in about 30 states. So that is being monitored right now. And websites such as the CDC's COVID data tracker, covariants.org, and the World Health Organization's tracking SARS-CoV-2 variants provide regular updates on data for the variants, just in case anyone's interested. A word about monoclonal antibodies. We've been using monoclonal antibodies earlier in the pandemic, mostly for folks that test positive and might be mildly symptomatic, but before they need to be admitted. So the patients who aren't on oxygen, maybe they're the elderly person or somebody with a transplant, they test positive, folks were being sent for monoclonal antibodies. And I think for a while, the ED was doing a lot of these infusions, but now there is actually indication, they got FDA approval for monoclonal antibodies being used for post-exposure prophylaxis. So these are for patients who are at high risk of progression of disease, but have not yet developed or even tested positive. So for the patients to be eligible, they have to be either not vaccinated or not fully vaccinated, or fully vaccinated, but they have a problem with their immune system that you expect to not mount a good enough response, such as immunocompromised patients or the very elderly patients. And they have to have an exposure to COVID. And the exposure has to be significant, such as like a household or close contact, or at a high risk exposure situation, like at a nursing home or a prison. And then if you satisfy those criteria, then the patient may be eligible for post-exposure prophylaxis with monoclonal antibodies. And there are 2 or 3 that are FDA approved for that purpose. And the one that we use at UCI is the Regeneron one. So this is the table from the NIH guidelines about treatment of COVID in non-hospitalized patients. So just to kind of call your attention to the first box over here, saying that if a patient is not requiring hospitalization or supplemental oxygen, they test positive, they have mild disease, they could either get the monoclonal antibodies as a treatment outpatient, and also the panel recommends against using things like dexamethasone if the patient is not on any oxygen. And then on the last box over here for you guys ED providers, it says if the patient is being discharged from the ED despite new or increasing need for oxygen, the panel recommends using dexamethasone for the patients to be sent home on if they're requiring oxygen for 10 days. There is not enough data to recommend other things such as remdesivir for them to go home on. So basically still we're reserving things like remdesivir for the patients who are getting admitted. A word about anticoagulation. Even though we know that patients with COVID are at higher risk of anticoagulation, there's been lots of studies about management of this issue. And so far the data hasn't panned out for just empirically anticoagulating folks. So basically you would do what you normally do. So a patient has COVID, you're discharging them from the ED, you don't give them any additional anticoagulation except for their normal one, that if they happen to have AFib, you do that. If they happen to have whatever, you do that. You stick to whatever that they are generally on. Otherwise, if you're going to do something different, it would be in the setting of a clinical trial. A word about the Merck pill. People have heard a lot about it. There's not actually a lot of scientific data that's out there. This is from the press release that Merck put out. The actual paper, manuscript, or preprint, that stuff is not out yet. So basically it's an interim analysis of 775 patients enrolled prior to August. And these are patients who have a lab confirmed mild to moderate COVID with symptoms onset within 5 days of randomization. So they are, and all patients has at least one risk factor for poor outcome, and they are randomized to either molnupiravir or placebo. And then they measured the hospitalization or death through day 29, and they found that it was 7.3% in the study arm and 14.1% in the placebo arm. And that accounted for 50% reduction in hospitalization or death. And basically no deaths were noted in the molnupiravir, even I have trouble, molnupiravir arm, and 8 deaths in the placebo arm. And 40% of the patients had viral sequencing data, and it was found that there was efficacy of this drug to the variants Gamma, Delta, and Mu. And the adverse events and drug-related adverse events were similar in both groups. And Merck has applied for emergency use authorization from the FDA on October 11th. And the FDA is planning to review this by the end of November. So this will be the first oral antiviral available for the pandemic. So it's going to be interesting because then we can maybe in the future treat COVID as we do with influenza, where we give them Tamiflu to go home on. So this is the similar kind of graphic for patients who are admitted to the hospital for their management of COVID-19. So just really quick, patients who are hospitalized, not on oxygen, they don't even need any dexamethasone. Patients who are presumably this group are in the hospital for some other reason other than COVID. This group hospitalized requiring just low flow oxygen, the panel recommends remdesivir, remdesivir plus dexamethasone, or dexamethasone if they don't have remdesivir. So here at UCI, we do the dexamethasone plus remdesivir. And for patients who are on high flow, you can either use dexamethasone or dexamethasone plus remdesivir. Here at UCI, we do both because earlier we were talking about the high viral loads to the patients with Delta variant. And also what we have seen is that the remdesivir is quite well tolerated. And, personally, as an ID physician, it just feels strange to treat a viral infection with just immunosuppression without an antiviral. So just theoretically, I feel like it doesn't hurt to give the antiviral, especially when it's well tolerated. And for patients who are rapidly progressing on their high flow, we add either tocilizumab or baricitinib. And for patients who are on invasive mechanical ventilation or ECMO, patients are recommended to get dexamethasone plus tocilizumab. So here is the a word about the immunomodulators. Here, there are a bunch that were kind of in different trials. Currently, in all the guidelines, they only mention corticosteroids, tocilizumab, and baricitinib. Those are the ones that have proven efficacy in various populations of patients with COVID. There's insufficient evidence for the other stuff that are listed here. And also, we're generally not combining them. There will be a few instances where I have heard of people getting both baricitinib and tocilizumab. Generally, that is quite immunosuppressive, and we are concerned for opportunistic infections. But sometimes in a act of desperation, some things we would do something like that for certain patients, but that is not really a standard. So earlier in the pandemic, there was a lot of talk about because of the ACE2 receptor and things, there was a lot of concern about, should we continue people's ACE inhibitor? Should we hold their ACE inhibitor? What about the ARBs, etc.? So now the guidelines say, if the patient is on an ACE inhibitor, just keep them on it. If the patient is not on it, don't put them on it. So just do whatever they're on before, just leave them. So that is kind of the recommendation on that. So future directions on therapeutics and testing. I found this as a kind of a nice picture, because a lot of things are being done with testing and therapeutics, CRISPR, nanotechnology, all those kinds of things. So a lot of science happening in the back. So hopefully many more new things will be coming, a lot of multiplexes and things like that, so that we can have faster, more accurate diagnosis and also better treatment for these patients. So a word about long COVID. It is now officially called post-acute sequelae of COVID, or PASC. So no case definition and no specific time frame that has been developed. The CDC recently proposed defining late sequelae as greater than 4 weeks after initial infection. The incidence varies depending on reports. It's thought to be between 10 and 30%. And the most common symptoms that patients are left with are fatigue, joint pain, chest pain, palpitations, shortness of breath, cognitive impairment, and worsened quality of life. And the proposed mechanisms there are a whole bunch, but I think it's probably a combination of all of these, which include virus-specific pathophysiologic changes, immunologic aberrations and inflammatory damage, sequelae of critical illness and being in the ICU, damage from secondary bacterial and fungal infections, cardiovascular deconditioning, and also iatrogenic damage. So there's a lot of the academic centers are starting clinics for long COVID. Here at UCI, I believe they are starting one that is run by primary care and internal medicine and family medicine, and with consultation with the varying subspecialties. So a word about reinfection. I think there's a lot of kind of people thinking that once they had COVID, they're immune to COVID. The true prevalence of reinfection is unknown. There is concern that the incidence would increase with circulation of new variants. And COVID can test positive for weeks to months after recovery, because as you know, the PCR testing, it will detect, very small amounts of the RNA. So PCR testing is not going to be helpful to determine whether it's a reinfection or not. Some of the testing platforms will give you a cycle threshold. That number can help you determine, because if that cycle threshold is basically think of it as kind of the viral load. So if the patient has a very low viral load, the cycle threshold will be high because it has to run multiple cycles to amplify. So if it's a high cycle threshold, generally we feel like it's probably going to be an old COVID or recovering COVID, versus if it's a low cycle threshold, then it might be an acute COVID in the setting of a person with the symptoms. And reinfection may occur more frequently in patients who had mild illness. So it was found that the patients who recover from an ICU type of admission generally had higher neutralizing antibodies and in their blood for longer periods of time. So their risk for reinfection is lower than a person who had mild disease. And it is unclear who may get reinfected, etc. And there's also talk that a person who had mild disease, your body produces the antibodies your body produces is kind of a broad shotgun approach to kind of try to protect yourself, whereas the antibodies that are produced by a vaccine is specifically for the spike protein and more useful in protecting the patient. So hence it is recommended that patients who have had COVID still get vaccinated. So now for the rest of the talk, I'm gonna be talking on the different things about vaccines and boosters versus third dose, etc. So vaccines in general remains the most effective way to prevent SARS-CoV infection. There are 2 mRNA vaccines available in the US for all adults, 18 and older for Moderna, and 16 and older for Pfizer. And Pfizer vaccine is available for children 12 to 16 years old right now. Next week, I believe the FDA is supposed to come out with a decision on the Pfizer vaccine for ages 5 to 11. So everybody's looking forward to that. And this is the data, US data in terms of how many doses or the percentage of Americans who have been vaccinated. So for fully vaccinated, as you can see, we're only at about 57.4%. Obviously for herd immunity, earlier in the pandemic, we said, we need about 60 to 70-ish%. However, with things like the Delta variant, which is highly contagious, we need higher numbers for herd immunity, and we need it up to about 85%, which we are quite short. What is interesting is that the population who are at 65 years and older is at close to 85%. So our elderly patients are actually much better at getting their vaccinations. So this is the picture, the graphic for vaccination. In the darker blue means better in terms of doses administered per 100,000 people. So the best is in Vermont and Puerto Rico, and then we are okay. We're in the middle of the pack, and I was surprised to see that New Mexico is actually, that's the darker blue in the middle of the, this over here is New Mexico. I was kind of surprised to find that out. And then here is the rates of people getting sick compared to the vaccinated versus unvaccinated. As you can see down here in the blue are the vaccinated folks, and the unvaccinated, we all see it every day in the hospital. So in August, unvaccinated patients had 6.1 times greater risk of testing positive for COVID and 11.3 times greater risk of dying from COVID if you're unvaccinated versus vaccinated. So this is if you broke it down, it's the same data if you broke it down by the different vaccines, because, there was some concern about the J&J or Janssen vaccine being less efficacious. But if you look at this data clinically, they all kind of bunch up over here. So getting any of the vaccines is better than not getting any vaccine at all. So one comment about pregnancy, and here is the data on the pregnant patients, and the light blue is pregnant patients who got their vaccines before pregnancy. The orange is prior to and during pregnancy, and then the darker kind of green color is during pregnancy. So altogether, if you look at it, basically vaccination coverage is like less than 40%, at best around 30% of pregnant people in the US are fully vaccinated. This is actually very disturbing. A lot of, it's very heartbreaking because the pregnancy is actually a risk factor for progression to severe disease, yet many patients don't want to get vaccinated because they're worried that the vaccine will harm their baby. So the recommendation currently from all of the society, including the American Society of the OBGYN, is for pregnant patients to get vaccinated. We have seen a few, I'm sure you guys have seen some that came in, got admitted, and who have died. They've lost their baby first, and then they died later. So it's heartbreaking, yet when I talk to my colleagues in primary care, they have trouble getting pregnant women vaccinated. They just don't want to do it. So, I mean, not the doctors, I mean, the patients, they just wouldn't do it. They're very skeptical about the vaccine. So try to kind of directly talking to your patients to convince them that it actually protects them and their baby. So vaccines adverse reactions, there's a lot of talk about this. So mild to moderate adverse reactions are very common. As you guys know, everybody's got their sore arms, etc. Anaphylaxis to mRNA vaccines is pretty much now thought to be 2 to 5 per million vaccinated patients in the US. And a little bit on the perspective, the odds of being struck by lightning in a given year for a person is 1 in 500,000. So it's much more likely that you might get struck by lightning than develop anaphylaxis to the vaccine. This thing called TTS, thrombosis with thrombocytopenia syndrome after the J&J vaccine, as of October 13th, there were 47 confirmed cases, more than 15.2 million doses in the US. So it's very rare, but it is a little bit concerning because patients could die from this. Women younger than age 50 are at the highest risk. And there were 2 cases reported following Moderna vaccine out of 388 million doses. So after investigation, the FDA felt that the increased risk is the same as the general population after Moderna. So they did not attribute those 2 cases to the Moderna vaccine. But for the J&J, this TTS is a potentially real thing. So it's something to consider. And if you think about it now with the potential availability of, they're letting us mix and match for the boosters. If you feel that the patient is in this category of a young woman, maybe you would want them to get a different vaccine instead of the J&J if they would go for it. So myocarditis and pericarditis after the mRNA vaccines in young people younger than 30 years old, there's a male to female predominance. These patients, it is a thing, but then most patients recover just fine. And COVID-19 itself causes a myocarditis that patients can have, long-term sequelae from, and that incidence is much higher than what is generated by the vaccine. So there's also no reason not to get the vaccine for fear of myocarditis or pericarditis. And Guillain-Barré syndrome is the rate is about 12 per million who received the J&J vaccine, and these are mostly in men age 50 and over, and most of these patients have recovered. So this is just, this is complicated, but this is just basically the FDA when they go and kind of look at the different adverse events, they put it on a table like this. They basically estimate, this is over a 3-month period, let's say, and they basically estimate like in each age group based on male to female, the benefits of the vaccine outcomes are prevented on over here, hospitalizations, ICU admissions, and deaths, and the potential harms during this period. They look at like, oh, okay, 1 Guillain-Barré, 4 to 5 TTS, myocarditis over here. And so at the end of the day, they still recommend vaccination for all of the age groups that we currently vaccinate for, which is everybody actually. So, vaccines in terms of third dose, there's sometimes confusion about why we're calling it the third dose sometimes and the booster sometimes, because the third dose, we use this term because it is noted that the series should have been 3 doses for the patients who are moderate to severely immunocompromised. So they couldn't mount their response, adequate protective response by the second dose. And so this is the third dose. So their complete series should have been 3 doses. For boosters are patients who are not immunocompromised. So their series is actually 2 doses and they are fully protected. And then later on, we give them a booster. So that is the difference. So when we talk about third doses, patients who are eligible for the third dose are patients with cancer, organ transplant, stem cell transplant within the last 2 years, or who are taking immunosuppression, moderate to severe primary immunodeficiency, or advanced HIV. And either Pfizer or Moderna, 28 days from the second dose. This is just data for the interest of time. I won't go into it, but basically it's saying not enough protection with the second dose in these organ transplant patients, but more protected after the third dose. And so breakthrough disease, this is just talking about immunology, initial exposure. Here's your primary response, secondary exposure. Here's your secondary immune response. We want patients now to get the booster, and antibodies naturally wane, cellular immunity persists, and the boosted by re-exposure or vaccine will give you that secondary immune response. And for the deltas, it's very highly contagious, and the speed often overwhelms this primary response, and hence we need to boost the patient and also ourselves. So here is data from UC San Diego, their health workers and their vaccine efficacy. As you can see, as the time goes on, by July, the last one where if we are to say that we have the similar kind of profile as our colleagues at UCSD, we are only 65.5% protected by July. So our immunity is waning. So the boosters for folks who received mRNA vaccines more than 6 months ago, the elderly patients greater than 65, people in nursing homes, people with underlying medical conditions, and we all fit into this category over here, people from 18 to 64 who are increased risk for exposure due to occupational setting. So, but these are for the mRNA vaccines, but for patients who had the J&J vaccine more than 2 months ago, the recommendation is to boost them. All patients, because the initial vaccine was not as efficacious, and mix and match based on risk and benefits. And so why should we boost? And this is, we're talking about all of us that we should get our boosters. Last I heard, only about 50% of the staff and docs and nurses have gotten their boosters. I am making a push for everyone here to get their booster. Why should you get it? Because it protects you from infection, because it will boost your antibody titer. Many viral vaccines that we know of actually need 3 doses, such as your hepatitis B, etc., and prevents long haul COVID beyond protecting severe disease. Because you might say, like, I'll probably do fine even if I don't get the booster. Yes, but many patients can get long haul, even if they're not very severe in their disease. And benefits to others, it prevents transmission and also protects our unvaccinated children and also and our high-risk adults who can't mount their own immune response. And why do we want to boost now? Why am I telling you guys this? Winter is coming. We are expecting that there's going to be a surge this winter, hopefully about 1.5 times this past summer wave, but it's hard to predict, especially we don't know if new variants are coming. Like I mentioned earlier, the Delta Plus is in many states now, but still rare. The UK is having their surge due to the Delta Plus. So there's that. And also holiday gatherings. If you get your boosters now, you'll be protected by Thanksgiving. So then, for the end of the year gathering, everybody's more protected. And side effects wise, it's pretty much the same or less than the second dose. So less worry about that. For Moderna, similar situation. And then this is just the match and mix neutralizing antibody study with the different vaccines and boosted with different vaccines. So the bottom line from this is, if you had Pfizer, you should boost with Pfizer. If you had Moderna, you should boost with Moderna. If you had J&J, you should boost with any of the other two over the J&J based on the studies, okay? And then this is just showing that the Pfizer vaccine is still active against the variants of concern, including Delta, Delta Plus, etc. And for boosters for us, UCI Health, basically you should have gotten your emails to make an appointment. It's at Shambrome Hall, building 55. And it's pretty much Monday through Fridays. You can even get your flu shots at the same time, one shot in each arm, and to get ready for the winter. So questions for me? Hello.
All right, another couple minutes for questions. Thank you so much, Dr. Shea. That was fantastic. It's great seeing all the information finally put together in one spot. Thank you so much for that.
Thank you.
One question about the booster and like the flu shot. Is there a certain time frame that we want to delay the administration between the two?
No, actually, we're saying that you can get one shot in each arm. So you can get them both. You'll have sore arms. It is thought that the COVID vaccine, you probably would have a little bit more reaction to compared to the flu shot. So if you had, it should be similar to your second dose, maybe a little bit less. So, but some of our colleagues have gotten one shot in each arm and did just fine. So you don't have to delay or anything.
One question I've been getting a lot from staff and family too is, are we looking in the future? Are we thinking this is probably going to be a yearly shot like the flu, or we just don't have enough data for that? Any guesses?
Yeah, there's not enough data for that. I think it has a lot to do with what is going on in the community, whether there's still, a lot of COVID, but it is thought that it is going to become endemic. So it's going to, every winter it will show up, but to what level, it's unclear. And so we don't know right now whether or not we're going to need repeat boosters and at what interval.
Oh, thank you. Any other questions? And if not, we'll take about a 5-minute bio break and we'll get started at 8:30 with Dr. Rivera's talk. Thank you so much, Dr. Shea. That was fantastic. Thanks so much for being here with us this morning.
Thank you. Bye.
And just to remind everybody, the link for the Survey Monkey for your attendance is in the chat right now. Don't forget. All right, well, everyone's finishing up the bio break. Ronnie, do you have any slides you need to share, or is it all video? Oh, you are quick. Wow. All right, perfect. We'll go ahead and get going with Dr. Rivera, who is the quickest share I've ever seen on Zoom. Love it. So for those who don't know him, Dr. Rivera is our Med Fellow, second year in his final year now, and going to talk to us about anti-vaxxers, which is something I know we never ever encounter. It's not really that big of a deal, but I'm real excited for this talk anyway. Dr. Rivera, thank you. Take over.
Thank you, Dr. Smart. So I guess I'll start with a case. I will say this, preparing this lecture has made my advertisements change quite a bit recently if I targeted advertising. So I hope you enjoy the journey with me. But let's start with a case. 42-year-old female presents for a COVID test after an exposure at her office this week. When offered vaccination after a negative test, she says, "Oh no, I'm healthy. I take care of my body. If I get COVID, I've got vitamins, turmeric. I don't trust the vaccine." What would you say to this patient, and how might you approach them, or what factors might be at play in their decision making here? I figured we're a smaller group today, so let's let everybody participate. You can unmute, you can join in into the chat.
My first question is always, if you don't trust medical science for the vaccine, then why are you in the ER? I don't actually say this to the patient, but this is my first thought.
Good. I like that. That's like our internal dialogue there that we have. Good. What else?
I feel like I usually ask, why don't you trust it? And I always get I did my research on Facebook and I found out all of these terrible, terrible things for it.
Good. Okay. I like the approach of asking a question why.
I make sure their
Thanks.
next of kin is updated in their demographic information.
You make sure what is?
Their next of kin is updated, has a good phone number.
Yeah, I'm not sure how
Start.
much. I'm not sure how much we can change somebody's mind in the typical amount of time that I have with patients in the ED. So I will usually, if I say anything, is say, "Well, I got mine, and I think you should get yours," and then just drop it.
Yeah, I
Yeah,
actually think
I'm
that's a
actually-
huge. Go ahead. Sorry.
Oh, sorry. I was just gonna say I'm similar to Dr. Suchard. I've pretty much stopped engaging. At this point, I feel like if someone at this point in the pandemic hasn't gotten immunized, there's pretty much nothing I can say. So I just make one quick comment about I think you should, and then I move on.
Good. Well, my
Yeah.
hope did. Go ahead. Who was that?
This is Kevin. So me and Matt had a dude, and I was really proud of this, and we converted him on the spot. And and kind of the stance I take on it is like the one we took that night. Whereas if they have like serious medical conditions that I can see in their chart, or if I look at them and they're obese, then I kind of harp on it a little more. But if they're otherwise healthy, then I'm like, all right, man, well, you're informed. You know, you're like, well, not completely informed, but you know what I mean? I'm like, you're an adult, you're making your decision, and I drop it. But if they have like conditions, then I take a minute to harp on it and hey man, I'm at least successful sometimes, so I'll take it.
Awesome. Well, I think you all have hit really closely on some of the points that I'm going to talk about today. My lecture today is on medical mistrust and anti-vaccination stances. It's kind of into the social determinants of health lecture series, and I think you're about to see why. My objectives today are to briefly discuss the historical background of medical mistrust among certain patient populations, discuss some everyday factors that lead to medical mistrust, and then understand the role that conspiracy theories and misinformation play, and then discuss some ways that we can combat medical mistrust and vaccine hesitancy. And at the end, we want to play a game that shows how quickly misinformation can spread virally online. Get it virally. So let's get started. Let's start with the background on why this is actually a problem. In 2019, the World Health Organization listed vaccine hesitancy as one of the top 10 threats to global health. So this means it's a huge problem for controlling diseases worldwide. As you can see, in 2019, the measles rates in the United States have started to climb again. Same thing in Europe. We've almost tripled the measles rates by 2018. So it means that diseases that we had previously controlled and had good control over are starting to come back again because of vaccine hesitancy. If you look at things like COVID-19, I think you saw this graph already in the previous presentation. There are states that are doing really well with vaccination and states that are not doing very well in vaccination. And when you think about so controlling novel illnesses and also control of annual illnesses like the flu shot, you can see that in the United States, there's a huge drop in the number of seniors who are getting their flu shots as well. People over age 65 are at some of the highest risk for contracting and dying from influenza. So these are starting to drop, and we're trying to figure out why are these starting to drop. It's not because vaccine availability has changed, but more like we'll see some of the other factors later on. The other important thing I want to talk about is that health outcomes are really affected by this. There are growing levels of mistrust and alarm, and it's alarming given that medical mistrust is associated with a lot of different negative health outcomes. So one is underutilization of healthcare. Another can be delays in seeking out care or delays in treating diseases that need to be treated. There are lapses in recommended cancer screenings by many patients who mistrust the medical community. There's poor self-reported health status, decreased mental health status. And then we have to remember that delaying seeking care will harm an individual. But if you have a communicable disease like COVID, delaying seeking care actually harms the community as well. And people who distrust the medical community are actually more likely to succumb to medical misinformation overall. So knowing that, we have to look at some of the historical factors that have contributed to medical mistrust, especially among certain populations. One thing is we have to talk about medical error. So about a quarter of a million Americans die each year from medical errors. Some argue that it could be considered one of the third leading causes of death in America. So the question becomes, why should people trust a system that makes so many mistakes and potentially harms so many people? Now, to put it in perspective, when we start thinking about how often we treat people, it's not considered that it's not considered that big of a percentage. But when people hear these statistics, like 250,000 Americans die each year from medical errors, it can cause problems. Another thing that we have to think about is American healthcare waste. Approximately 20% of healthcare spending in the United States is considered wasteful and unnecessary. America has one of the most expensive healthcare systems in the world without enjoying the improved healthcare outcomes. So the question then becomes, why should Americans trust a system that's so expensive and wasteful, but not nearly as effective as it could be? Then if we go into some other historical tragedies, we talk about Dr. J. Marion Sims. Does anyone remember who this person is? The picture on the right is a famous picture.
Yeah, he was like a famous gynecologist who used Black woman to, I can't remember what specific surgery, but he didn't use anesthesia on these women.
Yeah, very good. So he was often dubbed the father of modern gynecology. He had a statue that was recently taken down in 2018, erected in his honor. But what he did was exactly that. He did medical experiments on slaves and the children of slaves. And he was searching one of the things he was searching for was to cure the like vesiculovaginal fistula that happens after childbirth for some women. But he didn't get consent from these people, and he basically abused his power as a physician. And actually comes down to it, was actually quite a racist person himself, and considered slaves as less than human. And that's why it was okay to experiment on them. I think we all can remember the Tuskegee experiments, the syphilis experiments. This is one of the experiments that is most commonly cited in reference to establishment of internal review boards, or IRBs, for research. Basically, there were 600 Black Americans who were enrolled in a study of syphilis. About 400 of them had syphilis. And what was crazy is the study even continued on after penicillin was developed as a cure to treat syphilis. But the cure wasn't given to these patients, and it was considered largely a huge situation in which the Black community was taken advantage of by the medical community, and it sowed a lot of distrust in the medical community among Black Americans. Who knows who Henrietta Lacks is?
The Immortal Life of.
Yes. So Henrietta Lacks is the originator of the HeLa line of cells. This was the first time that human cells were able to be cloned and kept in Petri dishes, and has become one of the largest cell lines that we use in the world. It's said that if we spread the amount of cells that have been created from this line over the Earth, we could cover the Earth 3 times in the cells, which is crazy. She never received any credit or compensation for her contribution to science, which is another reason why this is historically a point of contention for Black Americans, because she contributed to one of the largest contributions in medical history, but we don't really know about her as much. Ones that we also don't talk about is basically the historical ethnocide and genocide of Native Americans. One specific project I can talk to is the Havasupai Diabetes Project, which was a genetic research project where they were looking at blood samples that were donated by Native Americans to look for any genetic elements that might contribute to the higher rate of diabetes among the nation's tribes. But what they ended up doing was, without going back and getting consent, they ended up taking the blood samples and doing even more genetic research than was supposed to be done on those samples, and without permission of the people who donated the samples. And in truth, these people were coerced to give the blood samples because they were told that this would be a project that would help the community by reducing the amount of diabetes in the community, which it did not do. There was also a forced sterilization of more than 3,000 women by the Indian Health Service, which is considered a medical atrocity against Native Americans. And then America even outlawed Native healing practices, calling them like heathen dances and things like that, and said that they couldn't practice their own rituals for healing. So it again created mistrust within the medical community by taking away their ability to practice their own traditions, but also by creating these terrible situations in which now Native Americans have some of the poorest health outcomes in the United States, which begs the question, why should they trust us? One of the things that I noticed, there was a study that looked at a ton of, it was basically a meta-analysis of all medical mistrust studies that have been done recently, which highly focused on Black Americans. But they found that all shared the notion that medical mistrust is created and perpetuated or sustained by structural inequalities that exist still in medicine. So in 2014, a study showed that there's a lower life expectancy for Black males and females and compared to their white counterparts. Higher blood pressure for Black males and females. So between 2013 and 2014, 42% of Black males had high blood pressure compared to 30% of white males. During the same period, 44% of Black females had this condition compared to 28% of white females. There are lower rates of flu vaccination. So we know that flu vaccines save lives, but in 2014, only 60% of Black and Latinx people age 65 and over got a vaccination compared to 70% of white and Asian people in the same age range. And then there's a strain on mental health. One review in 2015 found that racism was strongly associated with mental health difficulties, contributing to stress, anxiety, and depression. It was especially true for Asian American and Latinx groups. Any questions on some of the historical factors or any other, if you have your own personal cultural experiences or shared experiences in your family that you'd like to contribute, of times when your people within your cultural group or within your family may have felt like they were taken advantage of by the medical community?
No personal experience for me, but just reiterating on like medical apartheid and what like Ronnie was talking about, like a lot of our medical history, like in the past, like especially with like vaccinations, like with these, like a lot of the earlier vaccines were like experimented on slaves, and like even when we come into like the 1980s, some vaccines were like experimented on like people in Haiti and whatnot. So like when I like talk to people within my community, I could see why they have hesitancy. So yeah.
Especially in the Latin American community as well, where there is definitely structural inequalities and ability to access healthcare. You may find some medical mistrust from those communities as well. Okay, so I'll move on to some everyday factors and some other elements that we need to think about when considering patients' medical mistrust and anti-vaccine status. One thing is access and education, right? So affording internet access to get medical information can be difficult for some people who are on fixed incomes. Having a high-speed internet is a way to get appointments, but if you're like, I don't know if you've tried to schedule boosters or schedule appointments online for anything, when appointments are released, oftentimes those who have the highest speed internet or the easiest access to computers are the first to get up those appointments. And other people who are trying to call offices or make appointments don't have that same benefit because the appointments are already booked by the time they get to someone in the office to make an appointment. Some people don't even understand how to make an appointment online to see a healthcare provider so that they can actually get information about the vaccine or about healthcare, or try to access somebody who has information that they want access to. The other thing is it's really difficult to find where good medical care is available if you don't have online services, right? How are you going to read reviews? You're going to go to people and talk to them about who is their doctor and who do they like to see. Another important thing is understanding fact from fiction online. If you Google vaccines, almost 40% of the content that comes up will contain some sort of anti-vaccine information. And then you have to remember that people don't always understand how to search the internet. For example, if you Google benefits of vaccines, you get one set of resources. Whereas if you Google harms of vaccines, you get another set of resources. So people not understanding how to do this can have confirmation bias, where they Google something that confirms what their preconceived notion might already be. And then the other part we have to consider is that American education isn't really designed to teach people how to understand doing the research. So we may have people who want to go out and do the research, but don't have the requisite understanding of how to do the research. Another important aspect is healthcare coverage and expense. So economic disparities between racial groups really make it difficult for some people to get health insurance. It especially prevents people from getting healthcare. In 2014, about 20% of Black adults couldn't access health insurance compared to 10% of white and Asian adults. And then for Latinx adults, that was about 35%. In 2012, a study also found that predominantly Black zip codes were 67% more likely to have a shortage of primary care physicians than their comparative white neighborhoods. Another one that we have to consider is distrust of physicians. So there's a huge importance in our relationships between patients and then helping them to make decisions about vaccines. Essentially, pro-vaccine campaigns that rely on trust between physicians and patients may be ineffective, especially for patients who are vaccine hesitant, because people don't necessarily have the time or the ability, like you talked about, to make that kind of trusting relationship with their physician. For example, in 2019, the Ontario Medical Association did a public education campaign to reduce vaccine hesitancy called #AskOntarioDoctors. And their taglines were, have vaccine questions, ask your doctor, not the internet. And it was supposed to help those who were vaccine hesitant get them linked to physicians, but it really didn't work as well because people didn't necessarily trust the opinions of their physicians. So some people might suggest that health agencies try to build trust between physicians and patients by using scientific fact and also other methods of storytelling and information sharing and a narrative approach that might work better on patients who come from like a narrative storytelling environment. Another thing that we've had to deal with a lot this year is politicization of pretty much everything medical. We've seen all of our news stations will cover things in completely different ways, depending on which side of the spectrum that they fall on. We have to also we put medical practice into public domain where it's never really been before. So people are seeing research unfold for the first time in front of their eyes and not really understanding the process. And it builds distrust when things change. Exactly, it's very counterintuitive. And then we have to remember that we're in a world of publicity and gaining patients and income generating and finding patients to come to the clinics. And so we do these things where we get these pre-release of papers where I found this huge finding and I'm going to pre-release my paper before peer review to try to bring accreditation and credibility to my institution. And then we also remember that a lot of institutions do these press releases before they even get their peer-reviewed data to show the results of a study before it's been really scrutinized heavily. And this creates a lot of misinformation and politicization and back and forth in the public eye, which can create mistrust. Another thing that we really have to pay attention to, and I think that this is what our social determinants of health series is really about, is implicit bias in healthcare. A study in 2016 found that many white medical students wrongly believe that Black people have higher pain tolerance than white people. 73% of them held at least one false belief about biological differences between races. Some of these beliefs were things like Black people have thicker skin or have less sensitive nerve endings and can endure stronger pain, or that they have stronger immune systems. The researchers noted that these beliefs are centuries old and that some 19th century doctors used them to justify the inhumane treatment of slaves. In addition to limited access to trauma centers that some communities have, people in predominantly Black areas have evidence to suggest that racial bias may prevent people of color from receiving emergency care or accessing emergency care. According to Frontiers in Pediatrics, doctors in emergency departments are less likely to classify Black and Latinx children as requiring emergency care compared to white or Asian children, or they're less likely to admit Black and Latinx children to the hospital after visiting the emergency room. And they're also less likely to order blood tests, CT scans, or X-rays for Black and Latinx Asian children compared to their white comparisons. If we don't believe that this is still an issue today, I bring the evidence of Dr. Susan Moore. Does anyone remember Dr. Susan Moore? Who is Dr. Susan Moore?
She was a professor at the University of Indiana, I believe.
Yeah, she was
Somewhere-
a physician also.
Yeah.
And she documented her mistreatment during COVID, suspecting that it was because she was Black, that she wouldn't have to endure some of the things that she had to endure, as such as begging for medications for pain because the doctors didn't want to give her narcotics, or trying to discharge her when she was still having pain and still having symptoms. And ultimately, when she was fighting for her right to not be discharged, they did a CT scan of her neck to show that she had new infiltrates in the lungs and tons of lymphadenopathy. That was the reason for her pain. And they started to treat her. But eventually they did discharge her, and she was discharged home. And within probably 12 hours of being discharged home, her son had to take her back to the hospital, where she died a couple of days later at a different hospital. She did a lot of YouTube videos, and you can see some of the things that she was talking about from her bed, these YouTube videos. And then the hospital released a statement saying that the hospital where she was treated released a statement saying that nurses and physicians may have been intimidated by someone who was such a strong advocate for her own care, and so knowledgeable in her own care, that they may have treated her differently than they treated other patients because of that. And it was such a baloney excuse, and people really, really retaliated against that statement. It was one of those, like, let's just blame the victim and make it their fault, instead of saying that we have a problem in our healthcare system where patients are treated unequally. Any questions on some of the more everyday practices, things that we experience? Do you want to share some of your own examples of everyday things that might contribute to medical mistrust or anti-vaccination sentiments?
I don't know, not relating to vaccination, but like with the whole like thicker skin and Black people, kind of just relating to like when I was in med school, like I just see like with sickle cell patients, I know we did that like lecture in the past, but like when I was in medicine, like a lot of these people, they'll come in with like sickle cell crisis, like they'll be in a lot of pain, and like some of my like attendings will be like, oh, they're just drug seeking. I'm just like, what that? But I was like, if it was like somebody else from another ethnicity, would they treat them like that? So I don't know, these are things I just wonder when I work sometimes.
Yeah, unfortunately, sickle cell disease is a disease that primarily affects people of color, right? And many, the large majority of people who have sickle cell disease are people of color. And then when you talk about drug-seeking behavior or addiction to opiates, you have to think about who were the individuals who originally introduced these people to the opiates that got them addicted, that caused the drug-seeking behavior. It's not as simple as this is someone coming in for seeking out drugs. There's a lot of complex things that contribute to it. So really good example. Anyone else have any examples?
Yeah, I just wanted to mention about the politicized vaccination stuff. It's very international too. Like I know a lot of our patients are immigrants, and they keep up to date with like politics in their own countries. So, for example, like in Mexico, there was a time when in Mexico everybody was saying that the vaccines were just full of water or something else, some other placebo. So then families that lived here, they're like, oh, well, my so-and-so family member is saying in Mexico that they're only injecting water, so they must be injecting water here too. Like, I can't trust the government here either. So it just crosses international lines, and I think that's really interesting.
Yes, an excellent segue into some of the next things I want to talk about. Very good. So with that, I'll jump into the role of conspiracy theories and some of the background behind that. I looked at one study that actually looked at people who believed in conspiracy theories. On average, they found that people who believed conspiracy theories tended to be less educated, poor, and members of minority groups. But that's not all studies have found that. They found that they can come from various spectrum. And interestingly, there are many studies that say that people from certain political affiliations, like Republicans, tend to be more willing to believe in conspiracy theory. But more recent studies have shown that it's actually probably the extremes at both ends of political spectrums or of a political spectrum that tend to be more likely to believe in conspiracy theories. We have to remember that these aren't all conspiracy nuts wearing tinfoil hats and locking themselves in a trailer somewhere, right? Instead, these are normal people who are trying to make sense of complex issues and using information at their disposal to try to make sense of it in a way that they can understand. They found that people who backed conspiracy theories were less likely to rely on a family doctor, or they were more likely to look to family and friends for information about healthcare. And then they were more likely to look to internet and celebrity doctors for their healthcare information. So the people who looked at doctors like Dr. Oz and Andrew Weil, they were the most likely to favor conspiracy theories, with over 80% of people who looked to like the famous doctors agreeing with several conspiracy theories. So this was like a study where they took a bunch of conspiracy theories and they asked patients, which ones do you agree with? And they looked at people who agreed with like 0, 1, or 2, or more than 3 of these conspiracy theories. So those who liked the famous doctors from television and the internet tended to believe more of the conspiracy theories. So what we have to remember is also that these people think that they're accessing reliable sources of healthcare, or what they consider more reliable sources of healthcare information than what traditional medicine is providing to them. Some of the things that I found really interesting were people who take herbal supplements were really highly associated with believing more conspiracy theories, or willing to believe more conspiracy theories. And that was also it was also vitamins as well was one of them, but just interesting statistics. We have to remember that there are a lot of common medical conspiracies. So things like the FDA and the government are holding back cures for cancer because it's more profitable to treat than it is to cure, right? You've heard that one before. Other people argue that fluorination of water is used to cover pollution in water, and that it makes it easier for us to drink polluted water. There are conspiracies that doctors vaccinate despite knowing the risks, or that doctors vaccinate because they don't know the risks, or that doctors are on payroll of big pharma. I wish I got my vaccine check. I don't know where it's going, but it's not coming to me. All the things like cell phones cause cancer. I wanted to poll you guys, any medical conspiracies that you've heard from family, friends, the internet, patients that you want to share?
Yeah, so yeah, no joke. I told some of my R1s about it, but a few weeks ago I was just walking to my truck and my landlady came up to me and pretty much just went on a tirade for like 5 minutes, and I kept trying to edge out the conversation and keep walking to my truck, but telling me about how doctors are killing people when we just killed their family member and stuff like that. And yeah, a whole bunch of stuff. And yeah, so I just told her like, yeah, you're right, but I'm one of the good ones. And I left that alone. You know what I mean?
Yeah.
No, I'm just kidding. I didn't say that.
And that's like, that's a personal attack, right? After all that we've suffered through this year and the work that we've put into trying to save patients in our communities, hearing stuff like that is pretty terrible. And it's just like a straight up attack on us as physicians. I love the fluoride in the water to sedate us. Cardi B's cousin's friend's fiance or whatever, in the case of the swollen testicles after the vaccine. Stem cells from babies makes vaccine. Yeah, and the hospitals are killing patients with COVID. We're putting them on ventilators because it's more expensive. So if we can get patients onto ventilators unnecessarily, we can make more money for each COVID patient that we treat, right? So patients accusing us of violating our own tenet to do no harm. Good. Another one that Karina, I talked to a little bit that I want to bring back is private messaging software and unmonitored forums. So I want you to think about, while I'm going through some of this data, how many of you have received a conspiracy theory or message from a relative? Like we call it the tia de WhatsApp. Like, you know, everyone has this auntie or a tia who is sending things on WhatsApp. And WhatsApp is how people communicate across country lines, right? It's a way for us to communicate, and there's no one monitoring what goes through on WhatsApp. There's no fact checkers, right? We're the fact checkers in our family. So we talked about how people will go to their family and friends for medical information. And you have to remember that these groups actually allow like-minded individuals to come together and live in a bubble of misinformation, right? Because it's a group of people who are all sharing the same information among each other. And you have to understand how powerful this is, because when you have 20 people who share with 20 people 5 times, that's 3.2 million shares. That can happen pretty instantaneously on these forums. Places like Parler that are actually actively seeking out to get away from monitoring and fact checking because they feel like this free flow of information is important. The development of websites like QAnon, which is like a whole nother theory that we have to go into about why people can believe things like QAnon. This is really dangerous because there's no one fact checking and there's no ability to monitor what's being said. Go to the chat, extended family all the time. So yeah, and this is actually funny because there are really intelligent people that talk about this, and they share things because it comes from what they would consider trusted sources, or it's usually really vague. Like my cousin's doctor at Harvard said that you should be doing this, or there is a team of researchers at the CDC who say that drinking lime and alkaline water will actually cure your cancer, things like that. And I'll talk about I'll talk about John Oliver in a minute. Okay, so I wanted to go through this also just to give you kind of a sense of the anti-vaccine timeline, and what we're up against isn't necessarily new. In the 1800s, there was a huge surge of smallpox in Europe, and there was the European anti-vaccination leagues that developed in response to this. In 1853, there was this thing called the Vaccination Act that was implemented to make sure that children up to 3 months of age were vaccinated against smallpox, but also it got extended to like 14 years of age. And this was in response to this, the Anti-Compulsory Vaccination League was developed in Europe, and they would do protests and they would fight against vaccines, and my body, my choice, and you're taking away my personal liberties. And this is where a lot of the religious arguments against vaccination started, because it was considered that the smallpox, the lymph from the smallpox that came from animals that was used to inoculate you came from animals, which were dirty according to the Bible. So this violates tenets of our Christianity or other religions. In 1879, smallpox kind of reached America, and the anti-vaccination leagues of Europe came over to America and established themselves there, or at least the ideals did. And then you have to remember in the 1970s, there was the DTP controversy, where the diphtheria, tetanus, and pertussis vaccine, a group of researchers found that there were neurologic problems that they had reported in people who had received the vaccines. But even though it was disproven, a documentary in 1982 called the DPT Vaccination Roulette, this documentary was produced that changed people's attitudes about vaccination. And then in 1991, there was Shot in the Dark, which was a book published about vaccination harms, and it was kind of like an anti-vaccination book. We have to remember that in 1986, another thing that gets cited a lot in America is the National Childhood Vaccine Injury Act, which was basically a way that Ronald Reagan was essentially trying to make sure that there was enough vaccine supply available in the United States, because vaccine producers were stopping because people were trying to sue them, and they were basically, with all this vaccine misinformation around, they were saying, well, forget it, we're not going to produce this vaccine if we're going to get sued for these neurologic problems or whatever people are saying. So people often cite this as a source, saying, oh, vaccine companies don't care what happens to people because they can't be sued anymore. And this is part of this act was basically enacted to protect the pharmaceutical companies and physicians against vaccine injuries. But ideally, it was really to improve the vaccine supply, not to remove them of responsibility. We have to remember that this also is where VAERS was created, the vaccine reporting site, where people report vaccine adverse events, but which also created a lot of vaccine controversies for us, because people can report whatever vaccine adverse events they want, and then they have to be verified. So people can look and see that there's thousands and thousands of reports, but not necessarily validated reports. And then there was the 1990s MMR controversy. This was the one where people, Dr. Wakefield published his study saying that vaccines can cause autism, which, although widely disproven now, still resonates in the discourse around vaccines. And then in the 2000s, there was the thimerosal controversy. Sorry, I'm pronouncing it poorly. But basically, it was that idea that there's this kind of mercury or some sort of toxin in the vaccines. And even though there are isomers of this substance, and the isomer that actually causes the problems isn't the isomer that was used as a preservative in vaccines, vaccine companies actually figured out ways to preserve the vaccines without using this chemical. And so it's not even in vaccines anymore, but yet it's still an argument people use against getting vaccines. And now we talk about today in the 2020s, we've got COVID vaccine controversies like the 5G and the data tracking, altering our DNA, et cetera. Okay, any questions on that? All right, so I want to talk a little bit about the role of misinformation. So I don't know if you've seen this. This guy is called, I think he calls himself King Vietnam. And this is to Karina's point about how there is tons of misinformation internationally as well that gets filtered over to us in the United States, which affects us as well. This guy is basically like the, I would call him the Alex Jones of Vietnamese media. So even though Alex Jones has been banned from platforms like YouTube and things like that, we can't ban people like this because they are in countries where there aren't protections to ban these kinds of things. Sorry, I'm reading the chat. And what he does is he gets in. This is like a YouTube channel that people can watch that runs like 24 hours a day. And there are families who will like stream this in the background, kind of like Fox News gets streamed in some households here. These channels get streamed all day in the background on TV. And he says things like masks are killing people and you shouldn't take the vaccine. And one of his famous things that people like to quote from him is, if someone invites you into their home and they tell you to put on a mask, you should give them the finger and tell them F you, and so it's like, this is the stuff that we're fighting against. So there are some personal barriers to fact checking in which people don't know how to fact check. There are language barriers, especially with Facebook. If you look at an article that has been fact checked on Facebook in English, and then you find a similar version of it in Spanish or another language, it doesn't have the same fact checking box over it that the English version does, because Facebook hasn't dedicated the resources to fact checking stories that come in languages other than English, or if they do, it's not as good at it. We have to remember the country biases. So social media platforms don't have the same resources to dedicate to fact checking in other countries. There was an experiment where a group of people who worked at Facebook created just like a generic user profile for an Indian American woman, and then put it up and didn't do any activity, and watched what happened when, sorry, not Indian American, in India, and watched what happened and what ads came across the feed. And there were some really interesting things that came across the feed that were basically all misinformation without her ever having participated in anything on Facebook. Let's see. And then the other thing, if you remember, is government control. In places like China, they prevent linking of resources in articles. So it makes it really hard for you on some platforms to click back to the original source and see if it's an actual validated source. So we have to be really careful about it. Any questions on that? So I'm checking the chat to see. Okay. All right. The other thing we have to remember is that there's always an emotional approach that's used in these. It's always a story about a child or a friend or a family member who died, and it usually contains a few facts, but lots of name dropping of doctors or institutions. And the facts never really matter, but what matters is the emotion that it invokes in the reader. One study of 265 university students between the ages of 19 and 36, they were given descriptions of fictitious vaccines and also narratives that were fictitious from those who were vaccinated. So basically what they did was they manipulated the frequency of vaccine-related adverse events reported in the narratives, and they presented it to the participants. They were also given at the bottom the credibility of the website where the information was coming from, whether it was like an anti-vaccine agenda or a neutral health forum. And then they gave the credibility of the statistical information on the occurrence of the adverse events. And the results of the study showed that the narratives had higher frequencies of vaccine adverse events that led to a greater perception of risk. So basically, people who read stories about adverse events from vaccines were more likely to believe those stories. But interestingly, there was no effect on the credibility or risk perception. So essentially saying that people who believe these adverse events related to vaccines, they had a bias towards the emotional experiences, but even when there was like the website wasn't very credible or the statistics were shown to be not credible, they still believed the story more than they did the statistics. Does that make sense? So basically we're not fighting facts, we're fighting emotions is what I'm trying to say. And then there has to be this discuss sensitivity and a sense of health purity that often comes into play here. And discuss sensitivity is actually something that's been studied pretty well. It's the notion that like vaccines contain artificial things or toxic, poisonous things or dangerous ingredients, as opposed to like homeopathic or natural products. It has been suggested it's rooted in a health purity attitude. Basically, it's a form of avoiding contamination, and this is what they call the disgust response. So basically, there are high levels of this sensitivity associated with disapproval of gay people, preference for ethnocentrism, and social conservatism. Other studies have shown that undergraduates and general population have linked higher levels of discuss sensitivity with negative attitudes towards vaccination, suggesting that it's a factor for vaccine hesitancy. There's also this thing called the moral foundations theory, which comes up a lot, and it proposes that moral decisions are usually made with quick and emotional judgments, and then later post hoc, you add your justifications after your moral judgment. So you make the emotional response and then find reasons to justify that response later on. Other research shows that vaccine hesitant parents actually strongly emphasize these moral foundations of purity and liberty. So basically, they think that vaccines violate purity if they contain unnatural toxins. And then they also curtail liberty, which they're seen to violate civil liberties because the government is imposing control on bodies. And the disgust is seen to guard the body and soul. So it's like a way of protecting your immortal soul and your human body. And these are the foundations of purity in this disgust response. If disgust is an emotion associated with having one's moral foundations violated, then vaccine hesitant parents will have a higher disgust sensitivity and may also perceive vaccines to be greater violations of purity and liberty. All right. And then there's the anti-mainstream movement that we have to remember, which is part of this like alternative treatments that people are looking for. People are always looking to downplay seriousness of COVID from the beginning. So what they did was they're like, let's suggest some simple cures to COVID, inhaling vapors or taking ivermectin or hydroxychloroquine, or just simple available things that we can do to stop COVID because they seem simple. So it's a way to downplay the seriousness of COVID. But they're also trying to be apart from the mainstream and be like this counter mainstream. People also try to avoid cognitive dissonance. So what they do is they bend their beliefs to match narratives. So for example, this is kind of like game theory, where if you go into a video game and you're in a room and your goal is to get out of the room, we've all been trained in playing video games to look for things like, oh, maybe there's 3 dots on the walls there. So maybe they do something at the wall there because there's 3 dots. But if a game designer accidentally put 3 dots on the wall without realizing it, they could lose their players to like trying to do something with these 3 dots on the wall that isn't supposed to happen. And I'm sure many of us have been really frustrated playing games where we think something's supposed to trigger the next event in the game and it doesn't. And then you have to go on to like an online forum and try to find out more information about it. The other thing that we have to remember is this is why cults are so successful, because people want to avoid cognitive dissonance and they'll update their narratives. So like, remember when QAnon was saying, they were saying something about Trump was supposed to retake the presidency on a certain date. And then when that date came and passed and he didn't, the date was updated or the narrative was updated. So what we have to say is that, people will update their narrative to avoid this feeling of cognitive dissonance, that what they believed was wrong in the beginning. So they can easily apply what they think to change that. I will suggest, if you want to talk more about misinformation, John Oliver did a This Week Tonight on some of these topics, and it was really actually entertaining and very funny, and that's why I was introduced to King of Vietnam. So I highly recommend watching. It's like a 20-minute clip, and it was really fun to watch. All right, just finish things up. Any questions on misinformation, mistrust, those kinds of things?
Question for you, Ronnie, with all of this, like all these barriers, social media and whatnot, do you still try to convince people or do you just let it be at this point?
Let's get into that. I see in the comment, counter mainstream is cool. Heterodox and antonym to orthodox. Nice. I love that. That's actually really awesome. Storytelling is an amazingly effective form of persuasion, for better or for worse. Good. Yes, they use this argument and relate it to updates in scientific information, like masking recommendations. Exactly.
Ronnie, I got a question/comment regarding your statement that the American education system doesn't do a very good job in helping people test reality.
Yes.
And while I agree with that, I don't think it's just American. I'm wondering how much of this is just people. We would like to believe that humans are much more rational beings, and I'm not sure that we are.
Yeah, and and we are capable of being rational in certain situations, but we have to remember what affects our ability to be rational. I think you're right, is that we will often, in order to exist in communities we have to give up some of our rationality, right? And to live with others. And so I think that this kind of group think and the coming together, like-mindedness is part of that, is we put aside some of our rational thinking for the benefit of our group and society, for better or for worse.
Yeah, and if the educational system has problems with reading, writing, and arithmetic, it's going to be much more difficult to teach critical thinking skills. I mean, think if you had to create an assessment for critical thinking skills, it is way difficult.
Yeah, and we often save our teaching on critical thinking skills for upper education, right? Like college level education, which is not accessible to everybody. So not everyone who is high school or elementary school educated gets that same experience in critical thinking. So very good.
Just wanted to chime in really quickly. Sorry, the elementary school teacher in me is like wanting to talk about this discussion for days. But just to quickly say, so I think that, Jeff, I think you have a really great point. So I think that it's not just our system that fails. I think it happens worldwide, and I think it fails in different ways. Ronnie, totally spot on that critical thinking is not taught until higher education. So many people drop out or get kicked out or suspended or for whatever reason can't access higher education, so they never get taught critical thinking skills. But I think, Jeff, to your point, I think a lot of the attitudes towards educational systems by country are heavily influenced by cultural priorities. And in the US, I feel like a big American priority is putting on this front that we are the best, we are the biggest, and we are the strongest. And it's we don't do a very good job of acknowledging our flaws or the flaws in our history. And so all of these books were written by the white male perspective, like in the past, and it's just never been updated. Whereas other countries may not have that, you know, we need to be number one mentality as the forefront of their cultural principles or ideas. And so I think that other countries have updated their textbooks and their educational perspective in a way that we haven't. Not saying that they're perfect, and you know there are things that we do well that they don't. But I think that's been a big shift in perspective that hasn't yet happened in the U.S. and people are starting to talk about it. But you know, textbooks always lag like 50 years behind change. So hopefully one day we'll get there.
Yeah. And that's actually true. Textbooks do not tell the whole truth because we haven't created textbooks that do yet, right? And the ones that do tell the whole truth aren't mainstream yet. All right. So moving forward, I love this quote: "When I know that you care, I'll care what you know." So this kind of summarizes what we have to do for our patients, right? Is we have to let our patients know that we care about their health and that we're not just checking a box or fulfilling a number. So how do we do that? I say stop the spread, and I'm not talking about COVID, I'm talking about misinformation. Unfortunately, so much of the responsibility for stopping misinformation gets placed on the individual. So companies and social media platforms really do need to take responsibility for fact checking and stopping the spread of information and dedicating resources to places where this is actually happening, not just within the United States. And they have to take the burden off the individual, because it shouldn't be your job to correct, you know, your aunt and uncle every time they send something wrong to you, even though we do it. And then we will work within our own families, and people will work within our own families. In fact, India has this really cute ad encouraging people to stop their families from sharing misinformation through WhatsApp. It was a really cute ad. In the John Oliver Tonight thing, you'll see it. It's really cute. The other part that we can't individually fix, but as a culture and as a system and as physicians, we have to earn back the public trust, right? We have done some pretty terrible things throughout history that have eroded the public trust in medicine. And unfortunately, we're fighting against that tide in history. So we have to work to make medicine more transparent and more understandable to patients, whether this is us at the bedside or in general, like the process of science and educating people to understand the process. We should try to help patients when we're at the bedside understand our decision process and why we make the recommendations by explaining our thoughts. Some people have argued that this is like the death of the experts. But the truth is that the way we're taught to think and what we're taught to do is different than just sharing our thought process to patients and helping them understand where we're coming from. We're not going to like educate patients into becoming physicians so they no longer need us and take our jobs away from us. We can use our expertise to educate them on why we make the decisions we make. And then we have to make healthcare more accessible to others. And then we have to make healthcare more equitable, not just available or equally distributed, because we've seen from the previous slides that making healthcare available isn't actually making it available. We have to make it equitable, and that people who need it have access to it when they need it. And those who have more need for it have more access to it. And then we have to educate ourselves about the harms of the past first, which is exactly why you're attending lectures like this, is to understand. Another part that we have to remember is community engagement. So I feel we failed the most with COVID vaccination in this place, because what we did was we said, hey, vaccines are available, go out and get your vaccine. And we didn't really do a good job of getting medical advice available or actually making the vaccines really available to people. We said, go to your CVS and get one. And the people who had access went and got them and used up the supply right away. And then we had to work hard to replenish the supply. So what we didn't do is we didn't go to things like places of worship where people spend a lot of their time. A pastor gets their community every Sunday, 52 times a year or more. They get their community to talk to them about things. And that's way more than they see doctors. And so we need to work with people in those places to get doctors there, to bring the vaccines to them. We have to go to job sites. I think Catalina was a really good example of where they brought the vaccines to everybody and had a really great vaccination rate because they literally just brought the vaccines to everybody and stuck them in people's arms. I will point to the trial here at the bottom. It was a trial of blood pressure reduction in Black barbershops. This was a pivotal study because what they did was they went to barbershops and they talked to people about their distrust in doctors and why did they not go for regular healthcare screenings. And they found that people were more willing to trust, Black patients were more willing to trust a Black doctor because of a shared experience and understanding of where they were coming from. And so this study shows that we actually have to go out to the communities. We have to engage with people in the setting of the community, understand what's important to them, and then make adjustments to make available the things that they need, like physicians of color, or making information available by bringing doctors to the barbershop and having them talk to patients. The other thing we have to do is we have to make it easy. So we said vaccines are available everywhere, but we didn't give people childcare to go get their vaccines. We didn't give people transportation to go get vaccines. We didn't give easy access to healthcare professionals so they could ask questions about the vaccines. We just said, go to the pharmacy and ask the pharmacist. And this is a person asking a random pharmacist about all their vaccine questions, which is probably better helped by one of us. So that's more about community engagement. Sangeeta talked about this in the chat, and I think this is such a huge thing that we don't do very well. We as medical professionals have spent decades training our brains to think in facts and figures and evidence and statistics, but that is not how the majority of people work in the world. Most traditions are oral and word of mouth traditions where information is shared person to person in the form of really intelligent stories. There's this really great book I love called What No Bedtime Story Means, which looks at different cultures and how they tell bedtime stories to their children and how those traditions of telling bedtime stories to their children translate into how they do in education. Whereas writing a creative story may be considered lying in one culture because the person individually has been taught to tell repeat narratives, specifically like Bible narratives. Like you can retell certain stories from the Bible very well, and the better you are at doing that, the better you are at storytelling. But to make up a story or to creative write might actually be considered a form of lying because you're used to retelling stories that have been told to you by your family members or your ancestors. So we have to remember that oral traditions is one of the most important tools at our disposal. And so we have to help people understand stories and tell them the stories about what we experience, what we see, and what's happening. You all have very powerful stories as emergency physicians that you can use to talk to people and tell your stories. Does anyone want to, well, for the sake of time, I'll go a little bit further. I'll go quickly. Another suggestion is the truth sandwich. So you want to help patients feel like you're on their side. So if they present to you misinformation, you take one truth from the information that they have brought to you and explain why it's truth. So basically like the website, the meme or the article or whatever, pick one thing out that rings kind of true from there, then explain one falsehood in the source, and then add another truth that's not from the source, something from your knowledge that you know. And then as we talked about the disgust reaction that people have in this like moral purity and disgust of infirmity and disease and unnatural things, we should use that to take advantage of and show people what sick patients actually look like in hopes that we can activate their sense of purity and just encourage them to protect themselves from unnatural things like disease or ventilators or those kinds of things in a way to get them to protect themselves. And then the last thing is we have to have patients' empathy and compassion. You've learned a lot today about how much contributes to patients' attitudes about medicine and vaccines. In the beginning, we were talking about how frustrating it is to talk to people and how hard-nosed some people seem within their stances. But when we take into consideration some of these perspectives, we can't lump every patient into a single category as crazy or anti-vax, right? Instead, we have to do, I think what Dr. Wood said was take pause, ask questions, and then work within the patient's framework of understanding to try to help them get a better sense of the truth. What it essentially does is create closer relationships and allows us to better protect the patient's healthcare. And honestly, we owe it to patients after some of the things that we've done in the past. In summary, it's far more complicated than simple medical mistrust or vaccine hesitancy. By understanding the historical, social, cultural, systemic issues our patients face, we get a better understanding of their opinions. And through this understanding, we can find empathy in patients. And then with understanding empathy in patients, will allow us to combat medical mistrust and vaccine hesitancy and improve our overall health outcomes. Thank you. All right. So I went about 5 minutes over, so I'll quickly jump. Is there any questions before we jump into it? Just to give you a heads up, we're gonna do like a quick game that takes about 15 minutes. And I'll post up a link where you can drop your impressions of the game or your thoughts after the lecture. So feel free to jump in here. I'll copy the link and put it in the chat. You can jump on there. And then this is the link to the game that you should play. So John's going to break us out into groups. Dr. Smart, will you put us in groups and then have one person share their screen and play the game? And then we can come back in 15 minutes and talk about your experiences and whatever you posted on the Nearpod, okay?
Perfect. I'll give everybody a few more seconds to grab those links, and I'll also run around from room to room and make sure I drop it in every room just in case. So another couple seconds and you'll see the breakout rooms going around. And Ronnie, I think I made you co-host if I did it right. So theoretically, you can hop around too if you feel like it, but I popped you in one of the rooms too.
Very cool, thank you.
All right, here we go.
Hey, guys.
Hey,
Did everybody get on the game?
not yet.
Do you guys want to do it all together? Or do you want to do it on your own, like on your individual devices? Let's play it together.
Yeah.
Does someone want to log in and share their screen?
I can try. My internet's not super stable.
Let me see if I can get it. Okay, you guys can see that?
Yeah.
Start. Might have. I don't know how to play this. So why not walk around and choose the manipulator to get to the tactics inside? I'm down with that. I'm down with that, or I don't want to.
Down with that.
No. Sure, we'll do. What do you guys think?
I think at least if this was like written in English, using the word foreigner is kind of has a lot of weight to it and some negative use in the past. So if it was written in English, I think it's maybe manipulative, but also if it was a translation, that's a little bit harder to identify.
Any other thoughts? It's also a little exclusionary with meaning certain types of visas and residence permits. Not everybody's just allowed to come back. So what number would you guys give this?
5.
Five. Everyone agree? Any other thoughts on the number? Hey, Ronnie, for research purposes, do you need everybody to take this separately?
No, actually, just you can actually, is there a way to skip that part? You can just put whatever and get to the game.
Okay.
Sorry, I should have announced that.
Virus is man-made. Well, I'm just gonna answer for us. Very silent super spreaders. On helpless school children. Okay, that's not, I don't really find that manipulative. It's just kind of some facts, right? Face mask images continue to drop. I don't think that's manipulative. Very, okay, let's play the game. Pick an avatar, sweet. Okay, we're just gonna go. We're gonna be Joel. Yes, no, post this, not this.
No.
Post it.
Wonder how many COVID horses will come out of this friend's Corona coaster.
Okay, that one, yeah.
Okay, posting that. Clearly wasn't the key to influence. You only got 3 likes, credibility low.
Oh man.
Check out some other posts. My dog has gone missing, please help. Send flowers. I'm not sending flowers. Let's go look for the dog. Here is a new profile picture. Do you wanna comment or like?
Is this, are we trying to be an influencer? Like, what are we doing? What are we
I
trying
don't
to
know.
You're trying to earn credibility by being a provider of misinformation. But right now you're learning about how to do it.
We gotta get people to like us first. So yeah, like this.
Just like it. Fun fact, blue whale's largest animal. You are always fake news.
Yeah, do it.
Yeah, that's fake.
Sweet, things back to my feed. Big pharma-owned company destroys precious rainforest. Versus nature.
Search for posts.
Search for posts or ignore?
We're trying to misinform.
Yeah, search for posts.
Okay.
Up that toilet paper versus nature.
My dad told us due to COVID stockpiling to 30% of deforestation, murder, save the
Ooh.
whales.
Ooh.
Check out more. I've seen enough.
I mean, I want to say those whales.
Bump it.
Check it. All right. Story's interesting. Let's not jump to conclusions. Toilet paper versus nature. Find more posts or enough.
Yeah, that's enough.
Funny, everything newsfeed is about toilet paper. Congrats, you created yourself a filter bubble. I am shook if that is ads. Right, that explains ads. Posts with the most likes all tap into negative emotions. Now that you mention it, or really, Sherlock, do you want to go back and look at more posts? We can move forward. What do you guys want?
Lord.
Right. Our turn to weigh in. 3 words to show what we really think about toilet paper versus nature. Hugely concerning. Maybe alarming.
Potentially concerning. I don't know.
We have to use, we gotta create emotion here if we want to influence.
Oh, I thought this is like how we really. Oh, we're still trying to.
We're still trying to get this little credibility index up. We're not very credible right now. Let's post it. Bunch of likes. Woo, credibility went up. Want to brag? Let's brag.
Drop that mixtape.
Personal message.
Hey Joel, start a message on
It
that.
really resonated.
Oh God.
Do you want to join? Not co-frayed.
No, not yet.
Really?
I don't know. I feel like I want to make my own group.
We
gotta get credibility.
We gotta get credibility with the co-freighters, the not
Okay.
co-freighters. Oh, look at that! More likes. Sweet.
Oh, that's a
Those
lot.
are things
Popular I've ever been, guys.
spice up. Yeah, excessively emotional language.
All for the greater good.
All for the greater good. Ooh, we mastered a technique. Excellent. Imaginary, we're on level 2. Look at those likes going up. Let's go.
Oh, I just noticed our little credibility meter at the top.
Yeah, yeah.
Ooh,
Just
enough.
read this shocking article. Do you want to post it or not this one?
Post it.
it sounds complex. Nobody's gonna know what it means. Let's
But not
post it
this
and
one.
act like we do.
Oh, okay, okay. Post it. There you go. There you go.
I knew it.
Or your neck beard looks stupid.
Yep, yep, personal attacks. When confronted, personal attacks.
Oh, isn't going to do the trick. What did I still learning? Give me a break.
Oh, man.
All right, fair enough. You don't have a lot of credibility yet. Isn't that immoral? Let's pick a source.
Yes.
Dr. Hyde T-Pain. Yes, or you want a different source?
University of Life. It's pretty legit.
Pretty legit. All right, this is my source. Want to post this or not this one?
I think Nat Cofraid would love it.
Yep.
Ton of likes. Look at that credibility.
Hmm.
How awesome I am, or it's nice to be appreciated.
Nice to be appreciated. Go humble. Humble brag.
Let's check out the article. Vaccine trial successful, no harmful side effects. What do you want to you want to discredit or celebrate and share?
Yeah, well, they're not gonna report the harmful ones.
Yeah, let's discredit, man. Ooh, let's spice it up. I was silenced for trying to speak out. Posted or not that one?
Post it.
Silence.
Look at that, look at that, look at our likes. Check reactions or I have a fan club.
I have a fan club.
Check more or seen enough.
Enough.
We're in the news.
Misinformation? Me?
Oh, more likes after that. Good choice. Haters gonna hate or thanks? We got
Haters gonna hate.
Haters gonna hate. Oh, do you want to be an admin?
Definitely. That's the next phase.
This was Kevin's plan all along.
Let's do. Oh yeah.
I'm such a troll in real life, man.
We're a fake expert now.
Amazing. That took
All right.
like 2 minutes.
Master of puppets. Look at that. Look at that. Look at that. Nice. What is it about the content I'm not co-afraid that appeals so much to people? Pick 3 things. What do you think they want?
Top 2.
Scapegoat.
Sense of control, and then
1980s.
hear an explanation.
I think hair tutorials, but you know.
Jamie, real? You wait with that?
Do it.
Okay. 2 out of 3. And then we have to do it again. So sense of control, scapegoat, coherent explanation. Okay, let's find a news story to exploit. 5G radiation not linked to coronavirus. Rip this apart or not this one?
Nah.
People's Republic of Krakosia reports no coronavirus cases. That's not super exciting. Do you want to do the vaccine again?
Yeah.
Exploit it. What's next? Do we need to choose someone to blame or share the article as is?
Blame.
Gotta blame someone. Big shot NGO, big pharma, government, Bob from New York.
Big pharma.
Big pharma. Great. Post something. Finalizing plans for global trip, including a jelly chip in the coronavirus vaccine. You want to post this one or not this one?
Sounds pretty smart.
Let's do it. Oh, look at that. Look at that. We want to check more reactions or repost this and move on.
Repost.
Yeah, repost, move on.
The blinds are shut. What are they hiding?
Thanks, Abuelita.
Ooh, we got tagged.
Oh,
Oh,
and a
wow.
video of them destroying something.
Now getting dragged by riot police.
Oh.
Wow. What do you want to do with this? Use it or watch a cat video? Do you like cat
Advantage.
videos with it? Let's post something else. Post this or not this one?
Gotta share before they take it offline.
Share it. Ooh, look at that. These are big oaf. You got fact checked. What do you want to do?
Attack the fact checker.
Do it. Do you want to attack anyway? Or fair point?
Attack. Always attack.
I've just been watching you guys for the last like multiple minutes, and this is just amazing.
Great, great.
Oh my
If there's
gosh.
one thing I've learned in the past few years, when confronted with something, deny, counterattack.
Post or not this one?
Yes,
All right.
that sounds good.
Oh, look at those likes. Look at our credibility going up.
Oh yeah.
Thanks, champ. It's going viral. Wahaha or oh dear. Yeah, we're happy about that, right?
Yeah.
Let's do it. National protests erupt because of us. What have I done or nice? Nice.
Nice.
Yeah. Woohoo.
Wow.
Master.
Wow. I'm
Proud
John
of us.
Smart is a genius. What is this?
Oh, I did not make this. Ronnie found
People
this
are saying
game.
your group is behind this.
Oh, okay. I thought you made
Cry
it.
me a
I was like,
river.
this is amazing.
Cry me a river. Will do. Just lost a friend. That's okay. Proud of myself. We're proud.
Proud.
Yeah, we did it. Would you like to help us out? Oh, the breakout room is going. I'll complete the survey on our behalf if you guys want.
Thanks, Angita.
All right. Yes,
Cool.
do their
Good
survey.
job, team.
Good job, guys.
Okay, so hopefully y'all got to have a little fun, making sure your misinformation spread online, attacking fact checkers, creating fake sources of information, blaming the government for things, and using fake videos of a riot from some other time to support your claims. And you can see how easily people can put together these things, and how things like QAnon have grown so large and that people look for connections among things with our brains and that don't actually exist. And when we find some sort of meaningful connection to us, it's very easy to use it as a form of conspiracy theory. So any last minute shares before we move on? Thank you all for your patience as we went a little bit long.
Ronnie, this is amazing.
You. Dr. Stevenson's idea, he was very interested in talking about this. So I think it worked out well. I'll share you all the crazy stuff that comes up in my newsfeed now that I've
And
been
Dr.
searching.
Stevenson isn't here. It's a government conspiracy.
Exactly. He's at ASAP where they're distributing the real vaccine that we didn't get. Cool. All right. Well, thank you all very much for your time today. I appreciate it.
Oh, thanks so much, Dr. Rivera. Appreciate it. That was a great talk, great game. I love it, love it, love it. I'm popping 2 links into the chat right now. One is for Dr. Rivera's talk itself, and then one is for the game itself. And then Dr. Suchard, are you okay if we take about a 5-minute bio break and then we get started back with your talk? That sound okay?
Yes.
All right, perfect. Let's call it an even 9:49. We'll get going. All right, and as everybody's coming back from bio break, Dr. Suchard, whenever you're ready, I think we are good to go.
Great. So Dr. Smart, no more bio break. It's all over.
Oh, it's all over. If they didn't get it out now, they're just stuck. Too bad.
It is all over. Awesome. So I'm looking at roughly a 1034 goal to be done by. We'll see how well that works out. So I was asked by Dr. Stevenson to talk about the toxicology of alternative COVID therapies, which I thought was a really inspired choice that kind of combines my specialty and my interests along with this module that we're in about infectious disease. Objectives here that after studying the material covered in this presentation, you should be able to explain the known mechanisms of action of hydroxychloroquine and ivermectin as rheumatologic and antiparasitic drugs, their regular indications, and to list at least one purported mechanism of action for each of these when they're being used to treat COVID-19, that you should be able to outline the expected signs, symptoms, and treatment of patients with hydroxychloroquine or ivermectin toxicity, and then also to identify at least 2 additional alternative COVID-19 therapies and their expected toxicities. Now, before we go much further, I'm going to make a small disclaimer, which is that if you happen to be pro-Trump, you're not going to like a number of comments and a number of slides here, but let's see what happens. So first, we're going to start off talking about hydroxychloroquine. And here is the structure of hydroxychloroquine right here. We see down at the bottom, here is the chlorine atom right there. Here's the hydroxyl group. These 2 nitrogens right here have a free electron pair, and they're actually basic. They can bind H+. That will become important shortly. So hydroxychloroquine and the other quinolines are structurally based upon quinine, the original anti-malarial drug, and we see its structure right here. Here's the key component right there. And if we take a look, we see that same key component in chloroquine as well as hydroxychloroquine. And they have, as I already mentioned, this basic side chain where it can bind to H+ ions. And then the hydroxychloroquine has that little hydroxyl group off to the side as well. So how do these quinoline drugs actually work as anti-malarials? Well, they are alkaline, and alkaline drugs can concentrate in the plasmodial vacuoles, which are more acidic. Any kind of food vacuole or endosome or lysosome within the cell, the interior milieu is much more acidic, and you can ion trap the chloroquine and other related drugs in there. So here we see Plasmodium falciparum inside the red blood cell, and inside its food vacuole, it is metabolizing the hemoglobin, and it first goes into heme, which is toxic, and then that gets converted into hemozoin, which is non-toxic. However, chloroquine and the other quinolines prevent conversion of heme into the hemozoin, and that ends up killing the malaria parasites. So that's how they work normally. But hydroxychloroquine similarly inhibits lysosome and endosome function in our own human cells, and that can be used to treat autoimmune disease. So here, hydroxychloroquine is interfering with antigen processing going on inside lysosomes. Similarly, over here in the antigen presenting cells, it interferes with antigen processing, and it basically just tones down this whole system and decreases cytokine production. And so that is how it can have an anti-inflammatory response when used in autoimmune disease. Hydroxychloroquine has multiple proposed mechanisms of action against SARS-CoV-2. One is that it inhibits glycosylation of the ACE2 receptor, and we just heard from Dr. Shea how that is the receptor that allows the SARS-CoV-2 virus to bind to and then to enter cells. And then another one is the same mechanism that I talked about already, where it increases the pH inside endosomes by basically binding up the H+ ions there, and that adversely affects the endosomal function, affects endocytosis, viral RNA handling, and virion transport. And then there's another more hand-wavy mechanism where basically the hydroxychloroquine somehow blocks protein synthesis and viral assembly. Now, hydroxychloroquine and chloroquine prescriptions in the US, we see skyrocketed in March 2020. And what was the reason for this? Well, we see that on March 19th is when there was this famous news conference with Trump right there touting hydroxychloroquine, and immediately these sales went up. And in fact, it was only about a week and a half later that the FDA gave emergency use authorization, an EUA, to use hydroxychloroquine for COVID based upon some data at the time that suggested that it might be helpful. So here is a bigger timeline of events with hydroxychloroquine compared to these numbers with weekly prescriptions in the United States by tablets dispensed. So there was some reported in vitro efficacy back in February. Then Trump got on TV on March 19th. FDA granted the emergency use authorization. Then about a month later, there was a study in Brazil. Patients were having dysrhythmias. There was no mortality benefit. And then one of these early studies actually had to be retracted, and then ultimately the FDA revokes the emergency use authorization for COVID-19 patients. And now we have numbers of prescriptions that are higher than the baseline, but not much higher than baseline. So here's another look on a slightly different scale of the surge in prescriptions for hydroxychloroquine and chloroquine. And in response to this, just in the couple of weeks afterwards, we saw that hydroxychloroquine exposures reported to poison control centers basically doubled from the baseline. Doubled, so there wasn't all that many to begin with, but it did increase. And we saw that the first time prescriptions for hydroxychloroquine changed from before the pandemic to being mostly rheumatology specific to multi-specialty with record volumes of these prescriptions. And we are not immune. Emergency medicine was still one of the bigger prescribers, although rheumatology was still the largest. Now, despite these increase in numbers, there have been very few deaths from hydroxychloroquine or chloroquine overdose that have been reported related to COVID. There was one story that came out of an Arizona man in March of 2020 who died after taking a form of chloroquine used to treat aquariums. Basically, he and his wife were in their 60s. They had some chloroquine that they got from an aquarium and pet store, and he died and she was hospitalized but survived. So that doesn't seem very big numbers. However, multiple organizations, including the World Health Organization, have come out with position statements basically confirming that hydroxychloroquine does not prevent illness or death from COVID-19, although it does have an interesting proposed mechanism. Now, hydroxychloroquine and chloroquine are actually quite dangerous if you take it in large overdose, and the estimated fatal dose for each is roughly 4 grams or higher. And we can predict that someone ought to have a mild case if they take less than 2 grams, moderate in 2 to 4 grams, which would be taking all of these pills of hydroxychloroquine in this blister pack, and then severe, potentially fatal if they ingest more than 4 grams. And we would expect these following blood pressures. Of course, the more sick you are, the worse that is going to be. You can have QRS prolongation and you can have dysrhythmias as the toxicity increases. Hydroxychloroquine interacts with a whole bunch of different receptors and ion channels and can result in multi-system toxicity. There are a number of effects that are seen with chronic use, particularly if someone is on it for a very long time, you can get some retinal toxicity. There are neuropsychiatric issues, you can get photosensitivity. But if we're taking a look in what I'm more interested in with acute severe toxicity, it basically falls into 2 groupings. There are the cardiac and vascular effects, which are due to fast sodium channel blockade, potassium efflux blockade. Both of those can predispose to dysrhythmias. And then there are also alpha-1 adrenergic blockers, so you can end up with systemic hypotension. There are a number of pretty profound metabolic effects. Basically, everybody with severe chloroquine and hydroxychloroquine toxicity is expected to be hypokalemic. And some patients may be hypoglycemic, so that is definitely something to check. So here is a slide showing this effect of sodium channel blockade. Hydroxychloroquine cardiotoxicity can cause QRS widening on the EKG from sodium channel blockade. If you remember your basic science, we have this cardiac action potential, and in phase 0, that is the fast sodium channels opening, and we get rapid depolarization, which gives us a nice narrow QRS. But if we kind of slur out that slope because the sodium channels are blocked, we will widen our QRS. So with increasing cardiotoxicity from sodium channel blockade, first off, the person's sick, they're going to have a sinus tachycardia that will widen as the sodium channel blockade increases. That predisposes you to VTAC, which predisposes you to VFib, which predisposes you to potential death. So this is from sodium channel blockade. However, potassium efflux blockade is perhaps the more dangerous cardiotoxicity. Hydroxychloroquine blocks potassium efflux at the HERG channel, the human gene channel. This allows for potassium to exit the cell. And if we block that with hydroxychloroquine, it prolongs how long it takes for phase 3 to begin. And if it gets prolonged long enough, we can end up with an early after depolarization. And that can sometimes lead to an actual repeat early depolarization, which manifests as a PVC, a premature ventricular contraction, if it occurs just once. But it is possible that it can occur in a more prolonged fashion because the stage is now set for the R on T phenomenon. Here is the T wave going to occur when we're having this repolarization. And if we get an early after depolarization, we get an R on top of that. This is what is happening with each individual heart cell's action potential. But if we take a look at the surface EKG, what we're seeing is a prolonged QT because it's taking longer for this repolarization to occur. Then we get the next R, we have an R on T phenomenon, and that sets us up for having Torsades-de-Pointes polymorphic ventricular tachycardia. So we can get all sorts of different ventricular tachycardia from hydroxychloroquine toxicity. Fortunately, or perhaps unfortunately, we do have some good data about treating acute severe chloroquine toxicity, and this comes from France. There was this book that got published in 1982, a how-to book on how to commit suicide, and among the several different recipes it had, it said, why don't you go to the pharmacy, because chloroquine was widely available for malaria prophylaxis. A lot of French people go on trips to malaria endemic regions in Africa, for instance, old colonial holdings, and so chloroquine was available. And they say, well, why don't you just take several grams of that? And the result here is that there was enough cases of severe chloroquine poisoning that Riot and Baud were able to report on this significant case series, which is still referenced quite highly from the New England Journal of Medicine in 1988. And basically they came up with a treatment protocol that had early endotracheal intubation. And when I say early, I mean quite early. This is going into somebody's house who says, I just overdosed on chloroquine because of this book, and I took, say, 6 grams of it, and this person is awake, and they would sedate and intubate them in the field. So early intubation, IV diazepam, and reliance on epinephrine drips. And they actually showed some pretty good results with only 1 patient in their small series dying, as opposed to over 30% in historical cohorts. Now, these recommendations here are not from that paper, but these are consensus recommendations that came out very recently. I believe this is from an article in 2020. So if you have someone with mild chloroquine or hydroxychloroquine toxicity, basically all you're doing is monitoring and supportive care. It says to avoid class 1 antiarrhythmics, because those are sodium channel blockers, and we already have a sodium channel blocker. Interestingly, the class 1B, like lidocaine, are still okay. And it also says to avoid class 3 antiarrhythmics, because the potassium efflux blockade is basically what makes something a class 3 antiarrhythmic, and we already have that going on. If someone has moderate toxicity, we are now recommending that you actually start an epinephrine drip, IV diazepam, and some sort of treatment with some hypertonic sodium or sodium bicarb to help counteract the sodium channel blockade that is going on. And in severe cases, we are giving them essentially kitchen sink therapy, where they're saying this person is sick, unstable vital signs, we're going to start them on an epi drip, give them IV diazepam, the same sodium therapy as before. If they have a prolonged QT, which they probably do, give them magnesium therapy, and even to consider IV fat emulsion therapy. All right, this is allowing me to switch gears to ivermectin. Here is one particular political cartoon talking about horse sense, which seems to be anti-ivermectin. Interestingly, here's another political cartoon also talking about horse sense and having the sense here on the hooves because it's very cheap, which is clearly pro-ivermectin and anti-Dr. Fauci and the medical industrial complex. This is the saddest syringe I think I've ever seen with poison coming out of it. So on to ivermectin. Ivermectin has a very interesting chemical structure. It is a large lactone with this large ring right here. Actually, the product's called ivermectin is a combination of two different chemicals because there's a different R group right here, with 80% being one particular R group and 20% being another particular R group. And it is sold both for human use as well as for animal use, as we know. Ivermectin is used against various parasites because it's a neurotoxin against these parasites. What it does is it activates glutamate-gated chloride channels. So this over here is supposed to represent the normal neurotransmission that goes on inside this louse. And then over here, when you have ivermectin, it activates these glutamate-gated chloride channels. The chloride goes into the cell and hyperpolarizes the cell, so it is much less likely to then take that action potential and communicate it further down. So basically, you've turned off the bug's nervous system and it becomes paralyzed and dies. Now, why would anybody consider that anti-parasitic activity? Why would we use it for an antiviral disease? Well, it's been shown that ivermectin in vitro has activity against SARS-CoV-2 virus in cell culture by inhibiting formation of the IMP, the important alpha beta heterodimer. Okay, what the heck is going on here? So in the normal case, RNA viruses use these proteins called importans to take some of their proteins and to transport them into the nucleus through these nuclear pore channels. And once they're in there, there is a host response that occurs where this promotes the host kind of shutting down some of its antiviral activity and allowing for viral replication. That's why this protein wants to get in there, to allow the virus to multiply. However, if we destabilize this important alpha beta complex and it never forms, we're going to take less of the SARS-CoV protein and get it into the cell. The cell will be able to retain its normal antiviral activity, and there would be a better immune response from the host against it. So that is very interesting, that that is a mechanism that has actually been shown in cell culture to work. But the ivermectin concentration needed to do this is like 15 to 30 times higher than is achievable with typical dosing of ivermectin. There's a recent review article from the Japanese Journal of Antibiotics. I've never seen a study from there before. And they're talking about the effective concentration needed is as high as 2 micromolar, and it's necessary to administer tens of times the normal dose to obtain such a blood concentration. However, they say in actual practice, there are studies that show that it does have a good clinical response. Well, how do we deal with this data that doesn't seem to make sense? And they basically then just give a call out to magic, saying that they expect comparable benefits to the discovery of penicillin, and that ivermectin has been described as a miracle drug or a wonder drug. And that really does not seem particularly scientific to me. Beyond that one mechanism, there are several other proposed mechanisms for ivermectin versus COVID. One is that it inhibits RNA-dependent RNA polymerase, another that inhibits binding of the spike protein to another cell marker, CD147, and they think that CD147 and the spike protein cross-links RBCs with the viruses themselves, and that forms the thrombi that cause the problems in COVID. And then there's the STAT3 pathway, which I've never heard of before, that leads to many downstream pathologic effects, and we can block that. And so to me, this is kind of a path of increasing hand waviness, and it doesn't really make sense. And this kind of meets the criteria for me for Suchard's rule. Anytime you see more than 3 disparate mechanisms of action or 3 disparate drug allergies, you can tell that someone is grasping at straws, and I really don't believe much of any of it. Very recently, the Cochrane Library, this database of systematic reviews, which is some of the best evidence that exists, looked at ivermectin for preventing and treating COVID-19. And they basically looked at all of the studies and said that that was very low to low certainty evidence, they're uncertain, and that ultimately the reliable evidence does not support the use of ivermectin. But there are individual trials out there that show a benefit, and only some of them have been retracted. So now we're looking at some ivermectin prescription data. It began to increase substantially above the pre-pandemic baseline in December 2020. And so that looks like a peak. Well, just you wait on that one. So ivermectin prescriptions rose again in summer of 2020. The last peak on the last slide is dwarfed now by this peak going into summer of 2021. And ivermectin prescriptions are actually on a course now to possibly overtake hydroxychloroquine prescriptions. So we saw this previous March 2020 hydroxychloroquine peak. Ivermectin is spiking up. This data only goes out to August 2021. It is quite possible by now that it has exceeded hydroxychloroquine. And also we need to note that this data is only from human versions of ivermectin that have been prescribed and doesn't include veterinary ivermectin, which has been diverted. And most of the cases of serious ivermectin toxicity are from diverted veterinary sources. Now, several countries have adopted the use of ivermectin for COVID. This is especially true in South America. It's widespread in India. I like how they have it showing here in the United States as well. This is data from early 2021. And in the US, there are some physicians out there, I don't know where these people came from, what rock they crawled out from, but they're promoting ivermectin based upon personal opinion and maybe hope. There's this doctor here, Pierre Corey, who is a critical care physician and pulmonologist. And he's a member of this Frontline COVID Critical Care Alliance. It's a great name, but basically they're all out there saying that we're not going to be relying on randomized controlled trials. We just have this knowledge that ivermectin works. So just let us be doctors. It's a pretty anti-scientific viewpoint. And here he is testifying in front of Congress. And I ask anybody if they had this on their COVID pandemic bingo card. I certainly didn't. Here is the US FDA tweeting out, "You are not a horse, you are not a cow. Seriously, y'all, stop it." So reports of ivermectin exposures are certainly increasing, but the clinical details of human toxicity are really quite slim. So here is something from the Mississippi State Department of Health in August 2021, reporting that the Mississippi Poison Control Center has been seeing an increasing number of calls, and at least 70% are related to ingestion of livestock or animal formulations. 85% of the callers had mild symptoms. One person, they said, well, you probably ought to go to the hospital. And nobody was kept in the hospital due to ivermectin toxicity. So there's concern, but how many people are actually getting sick? There is a report out of New Mexico where one person is believed dead after livestock ivermectin drug overdose, resulting in a probe with somebody saying, I don't want more people to die. That's pretty basic health care, I think. I don't want more people to die. And you may have heard, I certainly saw it on the news, this report out of Oklahoma saying that gunshot victims are not getting care because of all of the ivermectin overdose patients, which turned out to be a misrepresentation of a slightly misrepresentative statement that one emergency physician made. And the hospital said, you know, the dude, he doesn't even work here. And we looked at our records and we certainly didn't see trauma victims being diverted or not receiving care. The American Association of Poison Control Centers has reported on the increase in ivermectin cases that are reported to them. So in this time period from January through September 2021, there's 1,440 reported ivermectin exposures, which is over 3 times the baseline that they had a year ago. But when we actually take a look at the medical outcomes, if we look at death, that's 0%, major effect is 1%, moderate is 10%. And the way that the American Association of Poison Control Centers defines major, moderate, and minor effect, like minor effect, they don't even tell anybody to go to the hospital. Moderate effect, we would consider mild. And really major effect, that's somebody who's probably going to need to be admitted, but not necessarily. There's a recent New York Times report on ivermectin and poison control centers that came out that shows that in Oregon, they had 25 cases from August to September. 5 patients were hospitalized, 2 went to the ICU. In New Mexico, they had 24 cases over a similar time period, whereas last year, the same time period, there was only 2. 14 people hospitalized and 2 died, a 38-year-old and a 79-year-old, and we have no clinical understanding of what their signs and symptoms were. Now, the expected effects per a CDC website is that significant ivermectin toxicity is going to cause mainly GI and CNS effects. GI effects, nausea, vomiting, diarrhea, and in fact, I made diarrhea in bold and blue here because this is described by many ivermectin users on social media. They say they're getting diarrhea and they see these strands in it and they're taking pictures of it and posting it saying, these are all the worms that came out of me. That's kind of interesting. And then CNS runs the gamut, anything from confusion, hallucinations to seizure, coma, death. The CDC described 2 ivermectin toxic patients who were admitted for CNS effects who needed no specific treatment. One drank an injectable ivermectin formulation for cattle and had confusion, drowsiness, hallucinations, tachypnea, and tremors and recovered after 9 days. And another had altered mental status after taking pills. They were disoriented, difficulty answering questions and following commands, but it improved with no specific therapy. So that's it for the big ones for hydroxychloroquine and ivermectin. And I wanted to get onto some other alternative COVID therapies that have been proposed. There's a whole bunch. Some of them I call less crazy supplements, like supplementing vitamin C, vitamin D. There's some good data about that. Zinc, and various other herbal supplements and oils and tinctures. I'm not super interested in those. The ones that are more concerning and interesting to me are things like bleach, hydrogen peroxide, povidone iodine, colloidal silver, and oleandrin. So I'm going to talk about Clorox first. I really like this political cartoon because where it is that they decided that they were going to end the word and put a hyphen, I think I would have put the L on this line. So what about bleach? I don't have much to say about bleach. It is fairly benign. Household bleach is a dilute sodium hypochlorite solution. Here's what hypochlorite looks like. It has a bleaching action. However, the sodium hypochlorite needs to be stabilized with trace amounts of lye, trace amounts of base, to keep its pH up, pH 11. Now that sounds high. It's really not all that high. Like hand soap, it has roughly the same pH. It doesn't taste good. It is certainly irritating, but it is not caustic. So if someone is exposed to household bleach, we don't expect much of a problem. If it's a higher concentration of bleach or they drank a whole bunch of it, then we might consider, this person might need to be scoped by GI. Moving on to another freaky doctor out there who doesn't even practice in the US, who was talking about nebulized hydrogen peroxide. An interesting response to this tweet was next he'll be recommending nebulized ammonia. So hydrogen peroxide is an oxidant and bleaching agent and antiseptic. It breaks down into water and hydrogen. Household hydrogen peroxide, which most people are going to be exposed to, is a 3% solution. It has various health-related and cosmetic uses. And blood and other tissues contain an enzyme called catalase, which causes rapid generation of oxygen bubbles. And so it foams up. And so everybody says, ooh, it must be strong, it must work. Exposures to household hydrogen peroxide, 3%, are typically benign. causing temporary mucosal irritation, like in the eyes, or if you drink it, you can have foamy vomit, sore throat, bloating, mild abdominal pain. Highly unlikely anything will need to be done other than a few burps. But large volume or higher concentration hydrogen peroxide exposures can cause more serious injury. Like you can buy online 35% hydrogen peroxide, food grade certified, oxygen for internal use. Do not use this internally. And if you get it on your skin, it can certainly cause some burns there. Those burns don't look all that bad. But concentrated hydrogen peroxide ingestion can cause corrosive injury to the GI tract. Here is a case report where we're looking kind of up from the stomach up to the esophagus, and we see some esophageal petechiae and white exudates. There's diffuse gastritis and a little bit of patchy duodenitis. And concentrated hydrogen peroxide ingestion can cause portal venous gas and GI pneumatosis. This person drank 35%. And look at all of that gas throughout the liver, and even some gas other places in the GI tract outside the liver. And it can cause strokes through cerebral air gas embolism if it gets into the vascular bed. Here's a patient with a positive MRI. Enough about hydrogen peroxide. Anti-vaxxers are now gargling iodine to prevent COVID-19, and I love this ER doc's response. F me, of course they are. So povidone iodine, as found in betadine, is a long polymer that's complexed with molecular iodine, which is an antiseptic molecule, and it kills bacteria. So if we have a whole bunch of these all linked together in a polymer, we'll have like this long polymer right here, the polyvinyl pyrrolidine, and it's complexed with the iodine, and then it releases free iodine, which is going to kill the bugs. Overt toxicity from povidone iodine is very rare with typical use, but it certainly can occur with non-trivial ingestions. You can get some GI upset, nausea, and vomiting. And in cases of significant volume ingestions, corrosive injury has been reported. But the most common adverse effect, if anything is going to occur, is acute renal failure, and in severe cases, hypotension. And you can get various thyroid effects. The iodine there is going to affect the thyroid, but interestingly, we can't predict if it's going to induce a thyroid storm or if it's going to induce hypothyroidism. Both have been reported. There actually was an article, well, it was really a letter to the editor in JAMA Otolaryngology, looking at povidone iodine mouthwash, gargle, and nasal spray to reduce the viral load of COVID-19. It was a small randomized clinical trial, but basically at each time point, they did not find any significant changes in viral load. They did notice, however, an increase in TSH, which is to say subclinical hypothyroidism, in almost half of their patients, but it resolved within 2 weeks after the topical therapy here. That's the best evidence that exists. Now, moving on to silver. Silver has long been known to have antimicrobial properties, meaning that it's toxic to bacteria. That, for instance, is why we use Silvadene as topical therapy, and you can even use various other concoctions that were very popular back before antibiotics existed to decontaminate a wound. So Silvadene combines topical silver with a sulfa antibiotic. And there is a supplement out there called colloidal silver that a lot of people like to use / misuse as a cure-all. And chronic use of this can cause argyria, a silvering of the skin. And in fact, there's this picture here that you can find on the internet of a guy who turned very deep silver, indeed blue, because what's happening here is that the silver atoms are actually depositing in the skin and they are being oxidized, the same thing that happens in photography when we use silver salts for photography in black and white pictures. The same thing is happening in your skin. It makes you look funny, but has no other known effects. And now here we see the last item I'm going to talk about, oleandrin. Here's Trump pushing the unproven coronavirus treatment, oleandrin, embraced by HUD Secretary Ben Carson and MyPillow's Mike Lindell. Well, with support like that, it's got to be good. So oleandrin is a cardiac glycoside that is found in oleander plants, and it can cause a digoxin-like toxicity. Cardiac glycoside toxicity can cause some autonomic effects. It will cause some depolarization of the baroreceptor cells. They send the signal up cranial nerve 9 to the vasomotor center of the brainstem that interprets this as, oh my God, I'm hypertensive, sends a signal down through the vagus nerve with increased parasympathetic tone, which slows down the heart, and bradycardia is quite common in someone who has cardiac glycoside toxicity. So I just mentioned the sinus bradycardia, and all sorts of cardiac dysrhythmias can occur with significant cardiac glycoside toxicity. We expect the bradycardia even at therapeutic doses, but the dysrhythmias are signs of toxicity. And there's all other sorts of systemic effects: nausea, vomiting, abdominal pain, and the visual disturbance that is sometimes seeing more yellow or green halos called xanthopsia, xanth meaning yellow, opsia meaning vision. So the most classic dysrhythmia from digoxin or oleandrin toxicity is paroxysmal atrial tachycardia with block. So what happens is we have these rapid P waves. So we're having this atrial tachycardia. There's increased atrial activity, but most of those are blocked at the AV node. So only a few of them get through. So it kind of looks like a flutter. It's a lot more irregular than a flutter. And then you can also see varying degrees of ectopy. So this is the classic digoxin or oleandrin cardiotoxicity. However, the more pathognomonic cardiac glycoside dysrhythmia is bidirectional ventricular tachycardia, which is ventricular tachycardia, but you have two different foci competing with each other and they flip-flop back and forth as to which one is creating the next beat. So it kind of looks like electrical alternans, but electrical alternans should be a sinus rhythm with a non-widened QRS. This is a widened QRS that flip-flops. Hyperkalemia is expected with severe cardiac glycoside toxicity. And we usually treat hyperkalemia with calcium, but we wouldn't really want to do it here because part of the problem with cardiac glycosides is they block the K+ going into the cells. That's why we have the K out. And then through a series of steps, it leads to increased calcium already in the cells. So the cells are already intracellularly calcium overloaded, and treating with calcium puts you at risk for diastolic heart failure, where the heart will seize up and then will be unable to relax. This is more theoretic than real, but if you think about it, avoid calcium to treat hyperkalemia with cardiac glycoside toxicity. The treatment for cardiac glycoside toxicity is mostly supportive, but there is an antidote, anti-digoxin antibodies. You will read about Digibind. Digibind is no longer available, but there's an almost identical product. The only difference is one is 40 milligrams, the other one's 38 milligrams. And we wouldn't know exactly how much to use, but if somebody is having life-threatening dysrhythmias, the empiric dosing is 10 to 20 vials. It's going to cost a lot, but you might save the person's life. And with that, I have reached the end of my talk about toxicology of alternative COVID therapies. I am not sure how I can actually stop sharing because I got rid of the screen that shows that for me.
Well, no worries. I think if you hover down or go back to your Zoom window, it should pop up for you.
Let's see.
John, you
if
can
not, I
also
might-
stop his sharing.
That would
Oh,
be
thank
the
you.
easiest.
Perfect. Let's see. I'm not used to having the superpowers.
I think from his, in the participants window, you can stop his sharing. Here, I gotcha.
Oh, thank you, Ronnie.
Thanks.
Perfect. I think I accidentally turned your video camera off instead, Sushard. Sorry about that. I got something. Okay, perfect. All right. So up next, we're going to have Dr. Kwa Nguyen with a team-based learning activity that we're going to split up into small groups with. Give me one moment. I'm going to put in the Survey Monkey for Dr. Sushard's talk, and we'll get started with the TBL in about 2 to 3 minutes. Dr. Nguyen, anything you want to do to introduce activity?
Hey guys, This is going to be over GI infections. This PowerPoint was actually sent to me by Graham. So any questions, comments, concerns, his email is gstevenson@hs.uci.edu.
Send all angry email that way. Gotcha. All right, the Survey Monkey link for Dr. Suchard's talk is in the chat right now. And then I'll open up the breakout rooms in just a moment, and I'll be hopping between all of them if there are any snafus. I think you just said it. Do you have the link for the TBL? I don't know if Graham sent it my way yet or not.
Oh yeah, I do have the link. I was wondering what that was going to do.
Awesome. If you want to drop it in the chat now, and then I'll go in every breakout room and drop it again, just to make sure nobody misses it. I think that might be the Zoom link.
That's the only thing he sent me. Was there like a...
Interesting. Let's see. Oh, I don't see it on my end. You don't think he emailed it or texted it to you?
Was it a file you were looking for?
I think he had a link to it. My guess would have been maybe like a Google Drive sheet, maybe is what we've been doing recently, unless he had it in a different format.
No, he just sent me a keynote, like a PowerPoint. And then I have the key to it. And then I just sent out the one without the key to everyone.
Oh, wait. Oh, did you email it? Or wait, how did you do it? Sorry.
I just sent out the, so I only sent it to the people, the residents. I typed in emergency
gotcha.
resident. I can send you the actual TBL. Here, I'll forward it to you.
Oh, cool. Perfect. And then as long as the residents can access it, we should be able to share in each breakout room totally fine. Perfect. Cool. I was like, I don't see anything.
Oh yeah, I sent it out to the residents. Sorry, I should have.
Perfect. Oh, you're fine. Okay, cool. I'll go ahead and split us up into breakout rooms, and then I'll hop around the breakout rooms to make sure there are no snafus. We'll regroup in about 45 minutes back in the main room to debrief overall.
Oh, we didn't finish.
No worries, no worries. Yeah, we're pretty close. All right, so we'll debrief and the main group once everybody gets back in here. We got a couple rooms still shutting down, and then we'll debrief.
Is everyone back? There we go.
Oh yeah, I think we're set now.
Okay.
Um,
Alrighty. Let me share my screen. Alrighty. So 9 questions. Let's go through it really quickly. An outbreak of acute gastro has rapidly spread in a middle school in Boston, Massachusetts. Students, faculty, and staff have become ill with nausea, watery diarrhea, and profuse vomiting. The average duration of illness was only 1 to 3 days. Which of the following is most likely the causative agent? What did you guys answer?
Noro.
Yes. The correct answer is noro. Was that Rory?
Yes.
Thanks, Rory. The most common cause of outbreaks of acute gastroenteritis presenting with nausea, profuse vomiting, watery diarrhea, affecting both children and adults alike. Norovirus is also the major cause of gastroenteritis worldwide. All right, next question. A 4-year-old female presents with a 10-day history of diarrhea. Her mother describes the diarrhea as watery and frothy, occurring with a frequency of 5 to 7 times a day. The child has nausea, occasional abdominal pain, and poor appetite, but no vomiting. She is taking swimming lessons in a chlorinated public pool. The most likely diagnosis is, what did you guys put for this one?
Crypto.
Yes, crypto. We were just talking in our group that like a lot of us, I think now use Sketchy, and I think we just commonly associate this with immunocompromised people. So I usually don't even think about this until I hear like HIV or something else going on. But apparently it survives in chlorinated water and produces this profuse watery diarrhea. It's a major source of infection in drinking water that's contaminated and in swimming pools. Treatment we use, actually don't see this very often. Probably if I was considering this, I would just like consult infectious disease. A 34-year-old male presents with a 10-day history of watery diarrhea. The stools are foul smelling, fatty, and greasy is the key word in appearance. 3 weeks ago, he moved to a rural area of West Virginia and has consumed the well water located on the property. What's the best treatment for this patient? This one we were thinking metronidazole for giardia. I think this one's classic. You see that fatty, greasy, foul-smelling stool.
I'm not familiar with well water though. Like I grew up in the Midwest and drank well water, and I don't remember giardia being part of that.
Well, you probably had nice well water. Alrighty, next one is a 3-year-old female presents with a 2-day history of nausea, watery diarrhea, and severe vomiting. She is vomiting 3 to 4 times a day and is having 4 to 5 watery stools per day. Although not feeling well, she's alert and interacts with her parents appropriately. The child's vaccination history is non-existent, and her parents have refused all the vaccines for the child. The child attends a daycare center during the week while her parents are at work. What is the best treatment for this patient?
Supportive care only.
Yes. This one, I don't really know what they were trying to go for with not vaccinated. I'm trying to think of like some things that could have prevented like a diarrhea on this child, but it sounds like she goes to a daycare and is having just like a viral syndrome. So yeah, just supportive care for a common gastroenteritis. Next is, it is most appropriate to use empiric antibiotic therapy to treat a patient with acute diarrhea when the patient is, this one we put immunocompromised. Actually, I had a patient on Monday who had, maybe if one of the attendings can weigh in. I had a patient who had HIV and just had acute like diarrhea. CT showed like an inflammatory ileitis, but his CD4 count was fine. I wonder if I should have started him on some kind of antibiotic therapy.
Did you do any stool studies?
We ordered it, but it never came back because he didn't have an episode for us.
Yeah, that's tough. I feel like stool studies in a place where you don't have follow-up is rough. So like immunocompetent, I don't even try, but that guy, that's tough. It could be from his meds, but there's a million other things too. So hopefully he has a doctor.
Yeah. Well, it sounds like he had good follow-up because he was taking his meds regularly, but that was one thing that I was a bit unsure about.
I think with a normal CD4 count, you shouldn't need to, because I mean, I probably wouldn't. I mean, I think if they had a low CD4 count or were known AIDS, then that'd be like immunocompromised, and I would start antibiotics then. But I think I would put them probably, I mean, they're treated for their HIV, right? So I don't know. That you need to-
Yeah, he was treated and he was like pretty much undetectable viral load.
I would probably still put them in the normal like colitis diarrhea category and not treat them, but that's just me.
Yeah, I think if they have normal vitals and they have follow-up, you could probably just watch and wait. And then their PCP can do stool studies. If they want to.
Other instances where empiric antibiotics are appropriate is if they have a significant fever, having bloody diarrhea, passing more than 8 stools per day, and if their symptoms are going on for longer than a week. An 11-year-old male presents to the ED with acute renal failure. 5 days ago, he experienced severe abdominal cramps, bouts of watery diarrhea occurring every 15 to 30 minutes, initially with small amounts of blood, but then became markedly more bloody. He was nauseated, but not vomiting. A few days ago, before the onset of his symptoms, he ate a salad with tomatoes and cucumbers that were grown near his family's barn where cows were housed. Which of the following is the most appropriate treatment for this patient? What were we thinking? Hello?
Our group, I think, got it right. Somebody say it.
Antibiotics.
Did somebody say E?
E is an egg.
E is an egg, yes.
Yes, Kenneth.
Answer is supportive care. Thanks, Ken. The combination of bloody diarrhea and renal failure in a child suggests HUS. The proximity of the family garden to potentially infected cows suggests EHEC. These infections are contraindicated, or with these infections, antibiotics are contraindicated as they are thought to increase release of Shiga toxin. I did not know that. Next is a cluster of acute diarrhea occurs in a group of preschool children who recently took a field trip to the State Fair of West Virginia. The symptomatic children pet the award-winning cattle on display. The affected children present with a fever and acute episodes of bloody diarrhea. 2 of the sick children are hospitalized with signs of renal failure. The most likely causative organism is?
We went with E. coli. We didn't realize that there was an association with live cows, though.
Yeah, me too. I also didn't know that. So just don't pet cows. Correct answer is B, EHEC. The bacterium can invade the bloodstream from the gut. Hemolytic uremic syndrome is a major sequela of EHEC infection. Okay, so just wash your hands after you pet the cow, resulting from an action of a Shiga toxin on small blood vessels and kidney epithelial cells. All right. A 27-year-old female presents with a high fever, abdominal pain, bloody diarrhea, and a maculopapular rash on her trunk. A few weeks ago, she returned to the US from Vietnam, where she visited family. She shows signs of septicemia and is admitted to the hospital. What is the most likely diagnosis? What do you guys put for this?
Typhoid.
Yeah. Answer is E, typhoid. Yeah. This presentation is classic for typhoid fever caused by typhoidal strains of Salmonella S. typhi and S. paratyphi. Vietnam is an area endemic for this organism. So Yuval, yeah, you're right. There's a Salmonella that typhoid does cause bloody diarrhea.
Quick note on that. I think that it is decreasing in Vietnam because of vaccination, but it can also look like dengue, which is very, very common and widespread throughout Vietnam. Just a little global health
Thanks, Dr. Rowe. And then, okay, last question. 14-year-old female is admitted to the ED with nausea, vomiting, and trouble speaking. She is placed on a ventilator and the hospital contacts the CDC. The CDC air delivers botulinum antitoxin to the hospital where it is administered to the patient. In this case, the antitoxin is used to prevent botulinum toxin from, from what mechanism of action?
E as in boy.
Botulinum toxin prevents the release of the neurotransmitter acetylcholine, resulting in a flaccid paralysis. This is distinct from the action of tetanus toxin, which blocks the release of the inhibitory neurotransmitters, glycine and GABA. Diphtheria toxin inhibits, this is like a whole, I need a photo to like explain this. But it inhibits protein synthesis by ADP ribosylating elongation factor 2. Is this like going to be on boards, or is this more for like a toxicology board question? Do any of the attendings know?
I don't think that's a fair question for boards.
Okay, cool.
Even in service, I don't think that will be on there, but anybody correct me if y'all think otherwise.
No,
Okay.
I think that, I don't think that that level of granularity may be on there, but from my personal experience, my written boards were very tox heavy, and it was like factoid type questions, not vignettes.
Oh, wow.
Yeah.
They love talks because there's a clear right answer that they can quiz you on like little tiny things.
Speaking from somebody studying for boards in like 2 weeks, I've definitely seen that on lots of practice questions.
Oh, wow.
Haven't taken the boards yet, but practice questions.
Oh, wow. Ready, guys? That was the last of it.
Awesome, strong work, Dr. Nguyen. Give me one moment and I'm gonna put in the SurveyMonkey link. We'll take a bio break and then we'll come back for one more game that might be a little bit of organized chaos in just a second. Okay, link is in the chat. We'll say come back at 11:01 and we'll get started. Okay, I'm gonna share my screen and gonna introduce the game. Here we go. Let's get this up. Get the Zoom box out of the way. Okay, I think we are good. Okay, so it's Halloween week, so we have to do something a little touch spooky, just for fun. So what this is gonna do, it's gonna be kind of a modified pub trivia format. So we're gonna say you and your friends are out camping at a lake and, you know, just having a good old time when all of a sudden this guy shows up. So the motto of a horror movie is you don't have to run fast. You just have to be faster than whoever you trip or whoever's behind you distracting the serial killer. So what this is gonna be, you're gonna be split up. We have enough for 2 teams. I'm gonna split you up into 2 Zoom breakout rooms. I'm logged in on my iPad and my computer, so I'm gonna be in both the rooms, but I'm gonna intermittently mute myself depending on which room I want talking. And what it's gonna be is each room will be a character, and every question you answer right, you can move forward or you can make your opponent move backwards towards a serial killer. At the end of the game, whoever is the furthest away from the serial killer survives. Whoever is the closest, you're gone. And that's game over for you. There are gonna be a couple things. So I'm gonna have your score down here that I'm gonna update in these numbers below you for how far away you are based on how many points you get and how many points you take away from the other person. And basically there are gonna be 4 rounds. I think we have enough time to get through all of them and still get out of here pretty early today, the way it's looking. I'll put up the questions in a pub trivia format. You'll have 5 minutes to talk about it as a team. And then we'll answer them together. To me, like a sniper format that I'll go over in just a minute, where you can only answer one, and once that question's been answered, it's out of play. Each round we'll roll the dice, and I'll show you how to do that in just a second. And the highest number will go first. So each round, each of the 4 rounds, will roll dice. If you roll the higher number, you get to go first, and the other person goes second. So they get second pick. Again, like I just said, whoever is the furthest away from the serial killer at the last round, you win. And whoever is closest to the serial killer and moves the least amount of distance, you are gone. You do not survive the horror movie. So how are you gonna roll dice? What you're gonna do is have one member on your team, Google just roll dice. It'll bring up this screen that you see right here. And you can pull 1 dice, 2 dice, or 3, 4, however many dice. You're gonna be clicking the blue ones, which have 6 sides. And I'll tell you based on what you're doing, how many dice you're gonna toss up there, meaning how many points you can get. And we'll go over that in just a minute. But keep in mind, have one member of your team have roll dice, Googled on their phone, ready to hold up to the camera. And that's how we'll be doing the rolling dice part in the Zoom format. All right, so every round of pub trivia has different categories. For this one, what it's gonna be is whoever rolls and they get to go first can pick from these 6 different categories. One, you can say, hey, we're going for the easy question. We're gonna do a 5-foot crawl. You add a little bit of points to your score. You can be a little bit more aggressive, add 10 feet. Ambitious with the harder questions, you can add 15 feet. If you really feel like screwing the other team over, you can sabotage them, which we'll go over in a minute. Or you can say, hey, I want to do something else. And we'll go over that too. So basically to sabotage someone, what you're gonna do, if you answer the question correctly, you tell me how you're gonna sabotage them. Are you gonna trip them? Are you gonna throw something at them? What are you doing to the other team to sabotage them? Based on how creative you are, if I'm bored with your answer, you get to roll 1 dice. If I think that was a great answer and you just rocked it, very creative, then you get to roll 3 dice. Same thing for do something. If you say, hey, if I were actually in a horror movie, here's what I would do to get away from the person. Here's what I would find. 1 dice if you're boring, 3 dice if you're great, 2 dice if you're mediocre. We're gonna say you're at a campground site, so whatever you can think of that you would get out of a horror movie using is fair game. I won't let you find a jetpack, but other than that, it's pretty much all fair game. So that's basically how it's gonna go. How you're gonna access the questions. Let me stop sharing my screen. Let's see. I hate when the Zoom box is hiding everything. There we go. Okay, perfect. So we've got that. I'm going to drop a link to a Google slide set that I'll be updating with each round of the trivia questions here. So here's a link right now in the main chat, and then I'm going to drop in each of the rooms whenever we break out into the rooms. And each round, I'll update the questions as we go. Whenever it's your turn to answer, I'm gonna mute either my laptop or my iPad, and I'll turn up the volume on the other one. So that way y'all can give your answer and the other group will be able to hear you between the two Zoom rooms. And then while you're talking amongst yourselves during the private part, I'll mute everybody so nobody can hear anything. It's gonna make a lot more sense as we go along, but that was still a lot of me talking about a lot of different things. What questions do people have at the moment?
No questions, just gonna learn as we go.
Perfect. Again, this one, it might be a little bit of organized chaos. We're gonna see how it goes. Hopefully it'll be a fun thing to do on Zoom, but we'll find out.
Dr.
All
Smart,
right,
that was your signature line when you're talking to your consultants. That was a lot of me talking. What questions do you have?
Exactly. I just talk a lot and I'm like, did anybody get any of that?
No,
All right, all right, I'm opening up the rooms now and you'll see one of me in each room.
So 3 total, right? Because you're adding the 2 plus the 1.
Oh, good try, Dr. Brown, but you gotta give me way better than that for 3. I feel generous with the 2. All right, a 6 and a 3. Are you adding that to yourselves or taking it away from them?
Take it away from them, I think.
All right, they are down to 31 now. All right, y'all's volume is going away, and then I'm bringing up Team Scooby with y'all's classical conditioning. Very, very classy today. All right, Team Scooby, what you got for me? We got 2 questions left.
We gotta do something.
Do something.
All right, doing something. Give me a preferred treatment for an adult who went hiking, drank from a stream, and now has a protozoa infection. What you got?
Metronidazole.
Nice. I will give you metronidazole. That's one of the first lines you might see on in-service or board exam. They might want to tinidazole. I don't think they'll ever give you both choices at the same time, but tinidazole would be the other one. So if you ever see tinidazole and you're looking for Flagyl, that's why. So, but Flagyl, totally appropriate answer. What y'all gonna do?
Think about it first. We got to make this spicy and get 3 dice.
So, you know
Give,
how
give me
like,
the flavor. Give me the
you know how
spice.
a dog is a man's best friend. So we emotionally manipulate the murderer. We give him puppy eyes and we make him think that we're weak and we can't run, right? And he's gonna feel so bad for us that he's gonna like untie us. And then he thinks that we're gonna join his side because he rescued us. But no, he unties us and then we start sprinting toward the van.
And then meanwhile, there's fireworks shooting in the background.
Yes, there we go.
If you as a team give me your best puppy whimpers right now of how you're going to seduce this serial killer with your sad puppy eyes, I will give you a full 3 dice for it.
Can I give you puppy eyes?
Oh, okay. I gotta wait. Keep it right there. I gotta show that to the team for proof. She showed me a really cute puppy. I can't. I'm sorry. Okay, y'all get 3. What you got for it? Give me a roll.
You want to just
if y'all would bring
all
your puppy
3
game, you could have this.
You want to do all 3 dice? Yeah, all 3 dice to our score.
All right, all 3 going to you. What you got? All right, I see a 6, a 6, and a 2, a 14. Beautiful. Oh, it's added up down there for me right there. I did that the hard way. All right. Oh, 45. All right, Scooby is taking the lead with emotional manipulation. Harsh. Okay, y'all's volume is going down. Team Shaggy is coming back up. All right, Team Shaggy, what you got? Looks like we have 1 left. We got a tick that you're taking off and maybe prophylaxing if you want. What you feeling?
So we decided the answer was the tick wasn't there long enough to require
are we eating right
prophylaxis,
now?
and that we would use tweezers and pull outwards
Ian, what are you eating?
in order to remove the tick.
Beautiful, exactly right. So CDC says
Frozen
unless that
pizza?
tick's been on there 12 hours or more, don't need any prophylaxis. And the tweezers, you want to grab it kind of at the base, as close to the skin as you can, gentle traction, and you're going to give a little twisting motion to almost kind of screw it out. The last thing you want to do is leave any bits of the tick left in there, or irritate the tick and make it puke everything up. Some old wives' tales will say put rubbing alcohol in it or burn it or things like that. The things you risk with that is you risk it vomiting all of that lime that it has in its belly into your bloodstream with that. So you want to be as gentle and loving with that tick as you can as you gently pull it out. Very, very nice. All right, so you all get a +5, bringing you back in your lead, but it is getting close. We're getting close to time, so we're gonna say this last round is gonna be the last one. Let me copy over the questions. I've got volume up on both teams if anybody has any questions before this last round.
Dr. Smart, can you use lidocaine to paralyze it and then use tweezers to take it out?
You could. I don't think I've really heard of people doing that commonly, just because honestly they're pretty easy to remove as long as you use gentle traction. I would worry a little bit that the lidocaine might be a noxious effect and might make it vomit a little bit. I don't think I would go for lidocaine. And honestly, whenever you pull these suckers out, they're really not that hard to pull out. I like the thought. Okay, here we go. The last round is pasted in there now. I'm muting myself on both teams, and then the 5-minute timer is starting right now. Good luck.
Oh,
Oh, there's one more round.
is it, for the first one, is it 10, I'm assuming?
I don't think so. It's a higher risk group, but I don't know if IV drug use in and of itself
5
is
or
considered high
10.
risk.
Yeah.
Yeah, it's 10.
It's probably 10, right? I mean, there's a possibility of being immunocompromised, I guess, but you're not sure. And I
I
would go
think
for
it's 10 or 15.
It's 10. Oh, 10. It's 10.
10. Okay.
Yeah.
If you have any risk factors, it's 10. 10 feet jog. A patient comes in with a high risk wound for tetanus. They have received greater than 3 total doses of Tdap, but the last dose was 7 years ago. Do they receive Tdap, immunoglobulin, both, or neither?
So
They just need Tdap.
Yeah, I think just Tdap. They
If-
had all
yeah.
their vaccinations. They
if
had
it's
more
high
than-
risk and more than 5 years, I think you need Tdap.
Yeah, and then I think you'd give immunoglobulin if they'd never gotten vaccinated at all.
Yeah,
right?
yeah, exactly.
Or didn't finish their vaccination series.
Yeah.
Cool.
And it's 20 with syphilis, she has documented anaphylaxis. Oh, dude, you got a sensitizer to this to the penicillin and give it anyway.
We had
Yep.
one of those patients.
Oh, really?
Oh, nice.
Iron-loving organism that is a classic mimic for appendicitis. Okay,
Oh, is that
a couple.
Yersinia inter.
Yersinia? Yeah,
Yeah.
remember that from Sketchy.
Yeah, Yersinia,
At
and
pet
then
store.
dude, Campylobacter can mimic appendicitis too. Apparently, I got that on Ross Review.
Oh,
Same.
so which one is the iron loving one?
I have no idea. I mean, the other one's the more well-known one, so it's probably Yersinia.
Yeah.
Oh.
Last one.
2-year child woke
rabies
up
shot.
with a bat in their room. Creepy.
Yeah.
You don't see 5 months. Yeah.
Yeah, you do rabies.
Immediate euthanasia. No, I'm just playing. You're done. Sorry, son. Oh man.
Been a good 2 years, but
Yeah, look who's that bat. Dude, I ran over a bat with a lawnmower one time. Had no idea. It was there.
Jesus, how did that even happen? How?
I don't know. I was living on a farm, but
You're just
sure it was
catching
a bat?
air.
it was unwounded or anything. And it was just, I heard this weird, crazy high pitched scream, and it was so high pitched I could even hear it through the lawnmower. And I turned off the lawnmower and I found it, and it was 100% intact. And it was the creepiest, most evil looking little creature I've ever seen in my life, dude.
Oh,
It was a nasty looking little thing.
yeah.
It's
Did you
tiny.
eat it?
No, I did pick it up though. I probably shouldn't have known what I know now. Not with my hands, but like with utensils.
Wait, so a bat was just laying on the ground in the middle of the day?
Yeah, we have a lot of bats at the farm. They live up like in these.
I know, fake news, man. I don't believe that story for one bit.
That's true, man. It's true. It's in the middle of the day. It's in the afternoon. I ran over a lawnmower.
We gotta figure out our sabotage and do something. Make it really good.
Yeah.
You know what I think might be a good one? We have well, it takes too long to activate. But I was gonna say, like, we've been secretly like infested with something. We could say we have rabies and then we bite Scoob or Shaggy
Don't listen, Dr. Smart. We're coming up with creative things over here.
or we could say we have everything. We've got the black plague of fleas that we've been incubating because we've been playing this for a minute.
Or
Plus
maybe
we got the deer ticks that we got the ticks that have that's the
maybe we've been slowly we've been catfishing Scooby for a long time now, and then we pretend to be a hot date and we invite them over for dinner, cook a nice meal for them, but then we put some Xanax in the food and he passes out. Then we lock him in a room filled with bats.
1 minute
Still
remaining. Both
currently
teams.
running.
1 minute remaining.
We're still currently running in the middle of a campsite drink.
Oh, but you know what? We could say we've been catfishing,
true, that's
and so
true.
we have the fake account on our little phone. We text them real quick, like we're his hot date. And then he gets
Yeah.
distracted from that. And in the
Yeah.
meantime,
Yeah, let's
we
do that.
stick some bats on him while he's distracted. Rabies bats.
For the rabies question, you guys, I think we also have to, do we have to give the kid also rabies immunoglobulin?
No.
Because he
Wait,
hasn't been vaccinated. Yeah, so you have to give him
Oh,
the
that's a good
vaccine
point.
and the immunoglobulin.
That's a good
Oh,
point, yeah.
shoot. Dang.
I just got a question yesterday from Rosh Review about that. That's how
Nice.
Roger that.
Um,
Oh, hey, knows
What
the
if
whole
we
series.
howled
Because
in
Smart's gonna be like, oh, what's the whole series and stuff? You know, it's like 1, 2, 4, 7, whatever it was.
I don't remember. Pull it up. What if we howled and called all the local wolves?
Oh, I like that.
That's a good
That
one,
one
yeah.
too. It's got to be complex though. It's got to be multifaceted.
All right, then the wolves come, and then we can ride on the back of the wolves because they're faster and we're kind of like a chunky puppy.
Yeah. Yeah.
And then stick the wolves on Shaggy.
But not the murderer.
Not the
'Cause we're-
Murderer.
Oh, we
We're
tell
on
them
their
to
side
attack
now.
Shaggy because we're
And that
petty.
is time, teams. All right, your
You have to
both
add the
volumes are
petty.
coming up, so be careful what you're saying. There we go. All right, everybody, give me a dice roll, and we'll get started and see who goes first this round. Give me 2 blue dice.
Big money.
It's not gonna be us.
Ooh, we got a 3 this time. Can y'all beat it? Oh, Jamie with the 8. Very, very nice. All right. Muting team Shaggy and team Scooby. What you got for me? Which one y'all want to go for?
Ooh.
Guys want to do the sprint?
Let's do the 15, yeah.
All right, going for the 15. Diagnosed 24-week pregnant female with syphilis. She's got well-documented anaphylaxis to penicillin. What is your standard of care?
Got to desensitize her to the penicillin.
You still want to give her penicillin? Dr. Collins. Good move. Very, very nice. This is the one time that you're like, I don't care about the anaphylaxis. I'm going to desensitize you. You still need penicillin because there's no better treatment for someone who's pregnant with syphilis. Perfect. All right, Team Scooby, you get 15. You are now up to 60, taking the lead at the last minute. All right, Yell's volume is going down. And Team Shaggy, what you got for me? Which one y'all feeling?
We'll take the 10-foot jog. The answer is you give it a tetanus booster.
Perfect. Yep, tetanus booster. Perfect. Why wouldn't you give the immunoglobulin? Do you know?
Because they've already had the vaccine series, so they should have effective antibodies.
Beautiful. As long as they've had more than 3 doses of their tetanus vaccine, they're good to go at this point. Perfect. All right. Oh, sorry, what?
I said, does that bonus question bump us up to 15?
I'll give you an extra 2 for it, just because I want to have you at an even number. All right. So you are at 60 now. All right. Y'all's volume is going down. Team Scooby, y'all's volume is up. Which one's next?
Oh, do you guys want to do something so we can like possibly roll 3 dice? What do you guys think?
Yeah.
I see nods. Okay. We'll do
All right.
something.
All right. 2-year-old kiddo woke up. There's a bat in the room. Super creeped out. No bite marks. What you doing?
We're doing vaccine and rabies immunoglobulin.
Perfect. You want to do both. Perfect. This is one that they love to do on exams. They'll be like, oh yeah, you woke up with a bat in the room. CDC says if it's a reliable adult who's pretty sure they didn't get bit, you can do shared decision making. And you can watch the bat if you have the bat, but there's any question at all, you just treat with both the vaccine and the immunoglobulin. Perfect. All right. What y'all gonna do? And let's see if y'all get 1 dice or 3.
Should we go
Are we doing the wolf thing?
All right, let's do it. We howl and we call all of our wolf cousins to come help us. And then we ride on the back of the wolves. And because we're really petty with that baby snack, we send the wolves to attack Shaggy and not the murderer.
Oh, that's harsh. Okay, y'all
With
petty. I
fireworks
like
in the
it.
background.
With more fireworks.
First of all, I love the. I don't know how many fireworks you have
Love those
carried with you, but
fireworks,
I like
you
it. All right, that gets y'all 3. I'll give you 3. All right, and I'm guessing because you are attacking Shaggy, it's going to be deducted from them, or are y'all going to say gives you a boost, a head start? Which one?
No, let's do a boost.
All right,
Boost.
last stretch of that van. What we got? Ooh, good roll it. We got an 11. All right, so you are at 71, and that takes a lead. But they are not out yet. There's still 2 questions left. Team Scooby, y'all's volume is going down. Team Shaggy, y'all's volume is back up. All right, Team
Yeah,
Shaggy, you
sprinkle
got
some
2.
showmanship on there, you know.
That was not volume down. Sorry. There we go. All right, Team Shaggy, what y'all got?
So we'll do, well, first off, did anyone come up with a good plan to sabotage before we pick that question?
I think we should just tie Scooby to a tree because he's a dog.
We tried
Already
that.
did
was
that.
Either way, we need to knock out this question because it's worth more points to them. Even if we get 1 dice, well, we need to get 2 or we're screwed. So yeah, sabotage someone. Our answer was Yersinia.
Oh, can I get a more complete answer? Yersinia intercalatica. I like it. Y'all got it. So iron loving organism, classic mimic for Appy. They like this one on test. You'll sometimes see it in real life. But basically they'll get right lower quadrant pain. You'll swear to God that they're in appendicitis. You get the scan, it's negative, and you just see some like lymphadenopathy around it. Likely Yersinia intercalatica. They love iron. Actually, if you give someone a bunch of IV iron, this is one of the things you worry about them becoming septic from. I've never seen that in real life, but that's a classic thing is somebody's on an iron infusion, becomes septic, worry about Yersinia intercalatica. Perfect. All right, what y'all doing? How y'all sabotaging? This is probably the game right here.
All right, team, it's gonna be worth 3 points. What do we got?
Okay, I got something.
Hit me, Dr. Brown. What you got?
This is gonna be super political and I'm gonna make this up as I go. Okay. So
Now I'm nervous.
That's my favorite start to a sentence.
Make sure it includes a bear trap.
we went ahead and we posted on Facebook that we were gonna have a rally for all the Trump supporters, okay? So we got this huge rally coming on in, right? Everybody's got their beautiful t-shirts and hats on. And we start having people have doses of ivermectin that they're just carrying in their pockets. And they come on over to us and they start injecting Scooby with all of these different doses of ivermectin, screaming,
Why the
"We don't
dog?
want to get COVID."
Shaggy's the whitey.
You guys want to take it from there and continue it and finish it?
I'm sold. I'm sold. That's 3 dice right there. If you want to make it better, you can, but I'm sold.
All right, let's just stop it there and leave the rest to the imagination.
Let's leave it there.
All right, give me 3 dice, and are you adding to yourself or taking away from Scooby?
We're gonna add to ourselves, I guess.
All
Already
right.
rolled it.
Oh, we got 8, 68. Oh, that is real close. What I will say is I will give them a shot at this last question that's left. If they miss it, I'll come back to y'all and give you a shot at it. And that's about the only way y'all can win right now is if they miss this question. Otherwise, it's not looking great for you, Shaggy. All right, y'all's volume is down. Team Scooby, we're down to the final moments. Give me a 5-foot crawl to make it to the van. What you got?
10 millimeters.
10 millimeters, correct. This always bugs the heck out of me because how often do we check PPDs in the emergency department? Not often at all, but they love this on exams. They'll give you healthcare workers, they'll give you people who are HIV positive, they'll give you people who are IV drug users and ask you what the cutoff is for all these different things. Perfect, very nice. And with that, Scooby hits 76, just barely makes it to the car. Unfortunately, Shaggy, I'm sorry, but the serial killer gets you. We are bringing the volume on both teams up. Any questions on all of that? We covered a lot of potpourri there, a lot of lanyard. What y'all got?
How are we gonna drive away as a dog?
I mean, you should have thought about this before you murdered
We'll make
Shaggy.
it work. We'll make it work.
This seems like a personal problem at this point.
It's a Tesla van that's already programmed to go.
Maybe Wilma's waiting for us and she's gonna be the driver. So
I like it.
Scrappy's in the car.
Oh, nobody likes Scrappy. Come on. Okay. So
Oh,
I'm
it's
gonna close the breakout rooms. I'm gonna put the Survey Monkey for attendance in the chat in the main room, and then after that, you are free to go for the day. That is all we have. Please let me know what worked with this format, what didn't, and if you hated it, we won't see it again. If you liked it, we might see it again. Let me close these breakout rooms, and then I'll drop the link in the main chat.
Recording in progress.
Are we good to go, Smart?
Oh, you are set free. Yep, make
Okay.
a run for it. Once you have the
All right.
survey, you are all good.
Thanks, guys.
Thanks. That was really good.
That was
Thanks,
really
y'all.
fun.